Hello, good morning and welcome to the February's Integrated Care Board, NHS Devon's board meeting. We're meeting in public rather than this being a full public meeting. So that means that at the end of the session, we can take questions from the public. We have one question that's been submitted in advance, but otherwise we'll do our best if there are additional questions from members of the public, but we may need to provide a later response. So first of all, welcome everybody, and I'd just like to give some apologies for absence. First of all, from Kevin Orford, from Kate Shields and from Anthony Fitzgerald. I'm very grateful to John Finn for deputising for Anthony today. And we have 3 members of our board joining remotely. Welcome to you online, and it's really particularly great to be here in our new premises. We've now relocated to Aperture House, and this is going to be a much better environment for all of us to be working in, but also saves us money. So thank you very much to Andrew Millwood and his team for taking this forward. I'd also like today to welcome Piers Tetley, who's joining us as Interim Chief People Officer. Thank you very much for doing that, Piers. And we also have just one member of public in the room, but welcome to anybody who's following these discussions online. So first of all, I'm just going to come to declarations of interest. Are there any changes to the declarations of interest as published? I'm going to come to Liz Davenport. Thank you, Liz.
Just to know, I'm no longer a director of Torbay Pharmaceuticals. Torbay Pharmaceuticals was sold to a private equity company, North Edge, at the end of last year.
Thank you for clarifying that, Liz. Right, next thing is we come to the minutes of the meeting that were held on the 6th of December. Are there any amendments that people would like to note to those meetings? No? So in that case, could we note those as being approved, please? And I'd also just like to confirm with Philippa that we are quorate for this meeting. Yes, we are. Thank you very much. So we come now to the section of our meeting, which is we call a citizen story. And this is Race Equality Week. And we felt it was really important that we acknowledge that. And we're going to start with a film that that's been put together. And I'm going to ask Andrew to introduce this item, and then we're going to have a discussion afterwards. Thank you, Andrew.
Thank you, Chair. So, as you mentioned, as it is Race Equality Week, what we thought we'd do is actually just get some views from some of our staff, colleagues and people in the community around some of the work that we're doing around race equality, given it's such an important issue. And so I'd like to just invite colleagues to watch the video, and then we can obviously have a discussion afterwards.
Thank you. Apologies, we're having apologies to those of you who aren't in the room. We're having some technical difficulties showing the video. I think what we'd be best to do while that's being sorted out is for us to go on. Are you happy, colleagues, if we go to the next item on the agenda and come back to that, just to see where we've got? So, promise we will come back to this very important item. We have the next section is both our chair's report and our Chief Executive's report. Our Chief Executive, Bill Shields, is going to be joining us very shortly. So again, I just propose that we just make sure that he's available to respond to any points on that. So I think it might be helpful at the next stage do we have Sam Wadham-Sharp with us? Because we could go on to the section which is around progress towards exiting from NOF4, so just bear with me. I think he's just going to be with us shortly. This is unfortunate, but we may need to come back to that item as well. So what I'm going to do is go on to item... Oh, he's here. Here we are. Thank you, Sam. Apologies, you're not late. It's just a couple of our items we're having some technical difficulties with. So thank you very much, Sam Wadham-Sharp, for joining us and to take us through your paper on progress towards NOF4 exit. And just to be clear, we're being asked to note the current position. We're being asked to note the new trajectories for urgent and emergency care, elective care, and the updated financial position, and also note the difficulties with providing assurance on meeting our target for exiting NOF4 in Q1 of 24-25. But Sam, if you could start taking us through the detail, and then we can take some questions. Thank you.
Sure. Good morning, everyone. So I'm Sam Wadham-Sharp. I'm Director of Performance and Planning for the ICB. So this is an NOF4 highlight report that sits alongside a series of flash reports that we send to Region on a monthly basis. This paper is looking at UEC performance for December. It's looking at leadership and strategy updates for December, month 9 finance updates, but because of the time lag on the available data nationally, it's looking at elective performance for November. What I'll try and do as we go through some highlights is just to give a bit of an update on where we are along some of that journey. So in terms of the overall paper, there is one proposed self-assessment change from last month's NOF paper, and that is a change in the exit criteria of developing a short-term financial plan for 23-24 that is signed off regionally and nationally. There's a recommendation that we change that current self-assessment level from green to amber, and that followed some check and challenge that we had at the last SIAG meeting with regional colleagues, and so that is the recommendation. Based on that, there are no other changes in terms of the actual exit criteria themselves. That would mean that the system and the providers in NOF4 within the system would currently be meeting 3 of the 9 exit criteria. Whilst we're only meeting 3 of the 9, I think we should be mindful that we have made significant improvements in our elective position. However, based on the fact that we will not meet the trajectories that were set within the year, we are showing as red rather than amber or green, but we have improved quite significantly through the year, and I can give some more detail on that as we move through. Sorry. In terms of some highlights within the actual report itself, so talking about the leadership and strategy section, so we've signed off the 24-25 operating plan process at SRB, and there is a further paper here today to sign it off at board. And we've also, in the leadership section, had the commencement of Sam Higginson in post as Chief Executive of RDUH. In terms of clinical strategy, we've signed off phase 2 of the PASS process, and there's a piece of work for us to do to ensure that we are really aligning what is happening within the PASS, within our wider UEC and elective improvement programmes, and making sure we're putting in the level of support through the PMO that we need to really drive the improvement in those particular areas. In terms of urgent and emergency care, we've seen some minor improvements within some of the metrics, but we still remain well behind the trajectories that we've been set and have set ourselves. 4-hour performance in December remained stagnant but stable at the upper end of our normal 61 to 63% range. There's a piece of work for us to do to really understand why is it, regardless of what kind of pressure we see ourselves under as a system, we never really move from between that 61 and 63% range. So there's a piece of work for us to do to understand that, but we do remain stable in that area. I would like the board to note that there is a national expectation that all providers and systems will hit 76% for 4-hour performance by the end of this financial year. We obviously remain quite away from that currently. In terms of Cat 2 performance, that continues to fluctuate, and we had a worsening performance in December, out to about 53 minutes on average, and there is an expectation, again, that all we don't monitor this at provider level, but at system level, we will meet a 30-minute Category 2 response time standard by the end of March. Within that, there's obviously some fluctuation with our ambulance handover positions as well, and that remains a significant area of concern for us. To try and tackle this, we've as part of the ops planning process, we ran a lock-in on last Friday to try and really understand the forecast of activity and our aspirations for next year, but also starting to review the level of spend that we've committed within the UEC space. So we've seen a 75 million commitment of money over the last 3 years within UEC, and have increased the headcount by 1,500. And there's a piece of work that we need to undertake to really review the best value in that area and understand what we're doing moving forward. In terms of elective, all of our providers have reforecast their trajectories following another round of industrial action in December and January. So what we are now seeing is a forecast of 673 78-week waiters versus an original trajectory of 0, and 2,988 65-week waiters versus an original trajectory of 1,707. There is a national expectation that all systems will hit 0 78-week waiters by the end of the financial year. I think I just want to give some context here that our original forecast of 65-week waiters at the end of this year was 16,900 in the first cut of last year's plans. We have made a significant amount of progress in that space. All of our providers are undertaking a challenge between now and the end of the year to improve those figures further, and we are obtaining weekly forecasts. So since that last trajectory set, we've seen a further 450 patients drop off that target. So we are continually improving, and we are really pushing ourselves to get to the lower end of where we need to be. It's also worth understanding the regional context. So the Southwest region is now the second best region performing for elective care in the country. It was previously ranked 7th and bottom, and Devon was the driver for that. So I think we need to understand that the improvement in the Devon numbers has really driven a regional perspective. But moving into next year, we also really need to understand how do we drive productivity within the services and the assets that we have, and really reduce our reliance and our over-reliance on insourcing, outsourcing, independent sector and high-cost solutions to delivering elective care. And that is a big piece of work for us. I won't dwell on the finance section, as I know that there is a different finance paper, but what I will say is that we still have a lot of work to do this year before we start planning for next year. So we have 24 programmes in train this year. 8 of them are currently off track for the year, and 5 of them are rated amber. We are putting in support around each of those SROs to understand what can we do to pull back as much as we possibly can do in the remainder of 23-24, whilst looking at what do we do next year. So in conclusion, I think the conclusion in the paper states that we will not meet our original NOF4 exit trajectory, which was Q1 of this year. We are working with Region, as the Chair stated, around a reforecast, both in terms of what does that timeline look like and what do the new exit criteria look like. I'd like the board to recognise the progress in elective care, but to understand that that is built on high-cost solutions at the moment, and we have a lot of work to do in terms of changing that for next year. I will be back in the meeting later to talk about planning for next year and what that means for us. But also, I think that we do have a real opportunity that whilst we remain in NOF4, that we could exit Tier 1 for elective in the new year, and that'll be a real drive for us. So happy to take any questions.
Thank you very much, Sam. I'm also just going to pass over to Bill Shields.
Thank you. I think just to add to what Sam said, we have had a number of meetings with Region, the Service Improvement Assurance Group, and we also met with Region again yesterday. They attended the System Recovery Board, and it's very clear that NOF4 exit will take longer than we anticipated. Despite the good work and good progress that's been made in terms of elective care, and also the fact that we will have delivered more cost improvement this year as a system than ever before. Pressures that we've seen, including industrial action and also cost pressures that we have had to deal with this year, has meant that we are very unlikely to exit NOF4 by Q1 of 24-25. We will be discussing with regional colleagues and national colleagues what that looks like going forward. And in fact, there's a meeting on the 21st of February with the National Chief Finance Officer to discuss our exit run rate in terms of this year's financial position and what our forecast looks like for next year. And the board will be apprised of all of those discussions and what that means for us going forward.
Thank you. And just to add to that, that we are absolutely committed to exiting NOF4. I'm going to bring Nigel Aitchison in next.
Thank you very much, Chair. I'd just like to build on what both Sam and Bill said about the work around elective recovery and the work that not just the team in the ICB, but particularly the teams in each of our providers have been doing. It's been actually quite remarkable work, I think, and it's been supported by Professor Briggs and the GERF team. It has brought together our teams to drive the quality of what we've been providing across our patch up, to try and make sure that the access experience and outcomes for patients in the specialties that we've started on is the same for all people over Devon, as a result of which we've seen those improvements which Sam pointed to. And the next suite, if you like, of specialties using that same methodology are starting now. But it is a real tribute to those colleagues right across our system, particularly our clinical colleagues and colleagues in trusts, for the work they've done in that space.
So thank you on behalf of all the board to all those who are doing that. I'm going to bring Alison Williams in next.
Thank you, Chair. I think it's really important to note on the back of that Devon is the most improved system in England on elective care. And that in itself, I think, is something that everybody should take a lot of pride in. It's been a huge effort and a great achievement. I know that the sort of consideration that not for exit in line with the original timescale will not be achieved will be a disappointment to people. But I think it's also important to recognise that that was always an ambitious target when you consider the scale of change and improvement that needed to be made. And one of the things that I'm keen to do over the next few weeks is produce a report for the national team which will be shared with the board, which actually identifies the scale of progress that has been made along that journey. So whilst the end points might not have been reached yet, it is really important to mark the progress that has been made. And I think that progress has been made both in terms of culture and attitude to improvement, as well as joint working and pulling together as a system, as well as turning the dial on some of the metrics. So whilst we're looking at the next phase of what the improvement journey needs to be, this is a point in time where I think that needs to be marked. So it would be helpful, I hope, to bring that to a future board meeting. The exiting tier 1 for elective is a massive achievement. And I think there are lots of systems across the country who would be very pleased if they were in that position. So I think holding on to those successes, particularly when it feels so hard for everybody, is important. It doesn't alter the fact that next year is going to be a challenge, that the UEC performance still needs a huge amount of improvement work to start to turn that dial, and the integrity of the plans to achieve that, I think next year will need to be stronger, Sam. I think it's fair to say, and that will need to be reflected in any revised exit criteria. But we should be in a position to bring something back to the board in respect of that, probably not at the next meeting, but the one after that. So that will then set the trajectory for the next financial year, so that the board can properly oversee the progress against the plans. And I would be optimistic in terms of the journey that is already underway, that you'll be able to see an acceleration then of the improvement actions because of the strong foundation that's been set during this financial year.
Thank you, that's really helpful, Alison, and much appreciated. I'm going to come next to Judy Hargaden.
Thank you very much. And I agree with everybody else's positive comments. It's really encouraging to hear about this progress, particularly in elective care. And also, we're getting much better reports and understanding on what needs to be done to get out of NOV4, so it becomes much easier to understand where the tricky issues are. You mentioned one, which was, I think you used the term insourcing and outsourcing and high-cost solutions. I think they were the same thing. Can you just give us a little more understanding on that? And, I mean, I think always as a board, what we want to know is how we can help with appropriate steers or whatever, but just clarify it a little for us, Sam.
Sure. So when we've been looking at productivity for next year, we've been looking at the amount of investment that we've put in to our services. So over the last 3 years in our elective care space, we've put in £50 million worth of funding, increased the headcount by 1,100 WTE, circa that number. But we've also spent £111 million on insourcing and outsourcing. So what we really need to understand is how do we use things like the GERFT methodology, taking the real positives that we've seen through the One Devon elective pilot, which is focused on a few specialties such as spinal, ophthalmology and orthopaedics, and spread that further and wider across the rest of our services. So we've picked another 6 specialties for next year, and really understanding where we are not benchmarking so well against either peer or national average, whether that's the number of patients on a list, our capped theatre utilisation, the numbers of patients that go through a clinic, the amount of follow-ups that we take in ratio to the number of new appointments that we undertake, but also understand where we're actually higher than upper quartile and benchmark very well, and how do we learn? So I think what we're really trying to understand through the first round of planning this year is if we have a commitment to get ourselves to upper quartile in terms of productivity using the core assets in terms of whether that be capital estate and then workforce, what does that then do to reduce our reliance on insourcing and outsourcing, because we are making the most of the resources that we already have? There will be a phased approach to that in terms of building up. We know that these specialties won't all be ready to go with that on the 1st of April, so it'll be understanding through the year how do we build up that productivity and capacity within our own solutions that will then sort of phase that spend out through the year. I think we do have some fragile services which will need propping up as we move forwards. That's clear, and there will be a longer term solution in some of those areas. But there is a real opportunity in some areas around using the resources that we've got in a better way, reducing our reliance on that high cost spend, but also how do we gain some of our market share back from the independent sector, etc., in some of these high volume, low complexity specialties. So what we're hoping to do is, with the first round of the operating plan that we'll be bringing back through board, is to have some clarity on what that might look like for this year. But the work is in progress.
And I think John Finn wants to come in and respond as well before I then come to Donna.
Judy, it'd be useful to have a real-time example of that. Would that be? So one of our biggest challenges over the last 4 or 5 years has been spinal surgery, where a large proportion of the lower acuity work has been outsourced to the independent sector. As part of the One Devon work, we have now a plan not going to the plan, it's almost in place actually, around repatriating the vast majority of that lower acuity work back into Devon. Now, that's meant a collective approach across the system to recruit two more spinal surgeons, but in terms of a lot more cost efficient, saves a lot of money because those 2 spinal surgeons cost an awful lot less than the 40% outsourcing. But what we've done now is that activity is repatriated, better for patients, closer to home, and the outcomes for patients are better. Now that's one of probably 4 or 5 examples actually, but that's the drive. How we've learned to do that this year, that'll be all over the operating plan for next year.
Thank you. I'm going to bring Donna in. Next, Donna Manson.
When there's progress, I often wonder how we're going to communicate that. It's double-edged. It's one edge off. We have a huge journey of challenge ahead of us, but the balance is to bring some hope to the changes that are taking place. So my question is, how will we communicate with stakeholders system-wide and with our colleagues and staff involved to get a positive message out there, and also continue to set the challenges that we face, because we hear it today in this meeting, but it's how do we get that so that everybody hears that.
Thank you, and over to Andrew Millward to respond.
Thank you, Donna. That's a really good point. So we've got a number of things planned. We are conscious that we do need to do a little bit more communications around our board meeting. So we've got some media lined up to do stuff around this, and also a note that goes to all of our system partners, because actually I've noticed a big difference since Sam's arrived, how he's professionalised, I think, a lot of our approach to how we do this, and I think it's important we let people know. It does come slightly with some risks because we're in because we're in North 4, particularly with our colleagues at HSJ, they tend to also look at some of the things that we're challenged on. But I think I'm pretty confident we'll get some really good coverage around this, because there's some excellent progress.
So thank you very much, colleagues. So if I could ask everyone to note the points that I raised at the beginning, and we're looking forward to an update on where we will be with our exit from the NOF4 date. So thank you very much to everyone. I'd also like to note that we're now ready to show our film and have our discussion around Race Equality Week. And there were, I think, a number of points that we might need to then reflect following that discussion that relate to NOF4 exit as well. So thank you very much.
My name is Regis and I work for Racial Equality Council.
Hi, my name is Leo Leong. I'm the HR partner for Equality, Diversity and Inclusion at the University of Plymouth.
My name is Tandy Hara. I am one of the non-executive directors on the Integrated Care Board.
When I was 13, I was misdiagnosed with an incurable eye condition. She diagnosed me with retinitis without any genetic testing or providing any genetic counselling, and basically told me that I was going to go blind at 20. So, as you can imagine, at the age of 13, that hit quite hard.
I have lived in Devon since 2005, and when I came down to Devon, that was from up Yorkshire and Bradford, which was more diverse in terms of the mix of the population.
A lot of it was a lack of awareness locally about racial differences when it comes to how issues manifest.
I am in Devon now, and that means that for that whole period, I have found Devon to be my home, and I found Devon to be quite welcoming.
There is challenges in terms of race, 100%. It's still Devon in terms of that. It's more of lack of knowledge. So microaggressions which happen, or racist incidents which happen.
So one of the most difficult things that I actually found when I came in Devon was to have access and support to a disease that only affects children from Black and minority ethnic backgrounds. So we've got a son who has got sickle cell anemia, and the first challenge was, how do we get supported and how do we get connected to people that got an understanding of that particular disease which affects people from Black and ethnic minority backgrounds? So up in Bradford, we had a whole community of, we had the Sickle Cell Society there. It was very thriving. But when I came to Devon, there was absolutely nothing. My son was the first child, at least as I remember it then, to have sickle cell in Derryford.
Devon is becoming more diverse, and there's a lot of people from the global majority coming here. Compared to other cities, it's not so big. So there is a lack of education in terms of that. If you've seen like the Black Lives Matter movement, I think that was the first time most people from the global majority really felt that they weren't alone. It created a bigger movement than Martin Luther King did. So it's like it was an incredible movement across worldwide, which created conversations and stuff. So since then you've kind of seen a new, let's say, like a new pedagogy of education in terms of like how people are talking about race and speaking about race, where kids are talking to your dads, they're like, oh, you can't say that, and people want to learn about race and stuff. One
thing I've particularly noticed is that there have been major developments through internet communications and communications as a whole. So particularly in the last few years, the online resources when it comes to rare conditions, a lot of that information sort of gets communicated and cascaded even down locally.
It's in our positions to keep those conversations going, to keep talking about them.
So racial equality to me means a consistent standard of care across everyone, regardless of racial background, ethnic background, or socioeconomic class.
If you ask me why it's really important, in a space where we had COVID, for example, where it doesn't really matter if not enough people have vaccinated, everybody, whatever color you are, is at risk. So we can't even afford to ignore certain parts of the population, because this isn't just going to be their problem, it's going to be everybody else's problem.
In terms of race equality, I think it's very important due to, like I said, the microaggression stuff. It kind of makes you feel less of, so you feel less human, and that humanization dies off, and then you start to question yourself in things that you do. So it's important for self-esteem, but it's also important for, in terms of education, like if once you start learning about race, you then start learning about hate crime, then you start learning about feminism, and you start, because they all connect.
So for me, the most important thing is that we need to move away from the space of planning, strategizing, organizing, thinking, to the space of implementing.
What I would like to see is the breakdown, or people starting to understand what actual systematic racism means. It's not you have white privilege. It's like there's a thing systematically built for you to benefit more than others, and that's a system that's there.
I think we've got a lot of goodwill, we've got a lot of people that really want to make a difference, and we've got a lot of effort being put into this.
So thank you very much, Regis, Leo and Tandy. And Tandy, of course, joins us today around the board table. And so I'd like to come to you first, Tandy, to say whether there are any points, additional points you really feel we want to be focusing on in our discussions today.
I suppose the last point I was trying to make is that I think what I would really hope we would be able to make is to move to the action space. Because I think personally we've had more than 50 years of making the case for doing something. We can't really be stuck in that space where we're still making the case, we're still justifying, we're still collecting data, we're still going out and proving that this work needs to be done. Because the more we get stuck in there, the more you get voices that think actually you're just making a big deal out of nothing. If we actually move out of that space, we don't need to convince ourselves anymore about why this is important. And I did give the example of COVID, for example. That was a very stark example of why if you do nothing about certain sectors of the population, the whole system crumbles. If you do nothing about supporting certain communities to engage very well with health, and you engaging very well with health with them, you do stock conditions that eventually come back to the health service. So even if this wasn't about them, which, you know, in many ways I think this debate tends to become a them and us thing, that actually is what stops progress. If we look at all this as part of treating the whole, part of making sure that everybody's part of it, because if everybody's part of it, we make more progress. So just to add that.
Thank you very much, Tandy. Penny, would you like to respond to that point, and particularly if we could focus our discussions around action, I think, and what happens next?
Yeah, thank you, Chair. So I was fortunate enough to be part of a programme called Getting to Equity, and I felt that I was fairly culturally competent prior to going on to that course. And it was very unstructured. It was full 5 days, and it was going deeper and deeper into a conversation that actually revealed to me and many others the lack of, the unconscious bias that you bring very often into your work. And that was really important learning for me, because 29% of the NMC register is made up of people from the global majority. And and that's similar for GMC and AHP. So we're very heavily reliant on delivery of our services for people from the global majority. And that's particularly pertinent, I think, for Devon, where there are huge disparity ratios. So we've got a high number of people working in fairly junior grades, but we do not have one chief nurse in the Southwest who is from the global majority. We have a glass ceiling, or we may call it a concrete ceiling, of people trying to break through to get into those senior posts. So I'd like to challenge all of us around this table to be visibly active in the work we do, because there is a difference between the population number of people from the global majority and those people providing care.
Thank you. I'm going to come next to Judy and then Andrew.
About 2 years ago, we had a report done called the Insight Report, I think. Pardon? NOUS report, thank you. I'm muddling up two different agencies that did reports for us on EDI. And there was a whole action plan that the trusts and the Integrated Care Board, CCG, did together. I'm not going to ask Andrew on the spot to give us an update, but I wonder if we could have an update. There were lots of action plans. I know there are people working on it. I think it would be very helpful to know what progress we've made since that.
Thank you, and make it clear who people can approach if they're unhappy. You know, who are the people in those leadership positions that we can come to. Andrew.
Thank you, Chair, and thank you, Judy. Yes, we did a report called by a company called NOUS, which was quite challenging of us, wasn't it? And I know many organisations have also done the same. I know Devon County Council have had a report that that highlights that we've got a long way to go, and it's the things that Tandy mentioned, I think, that is important, is let's get away from just talking about it and doing something. We have done some things. I'm very happy, Judy, to bring a report perhaps to one of the next board meetings about the actions, because we're about 3/4 of the way through the NOUS report actions in terms of delivery. We've also done some work with our international nurses. Again, Sunita, I think, came to our board, didn't she, and talked about the challenges of we spend a lot of effort bringing international nurses in, but actually, do we do our best to make sure they're welcomed, they feel comfortable working here, they have a great experience? And we're doing a piece of work at the moment with those nurses just to find out what their experience is and how can we help them. And also, we funded some of Sunita's time to chair a race equality group that looks at some of the things that we could do together. But I think the challenge I think we should pose ourselves is, I think we're all doing bits around this. Could we collectively do a bit more if we joined forces?
Thank you. Penny Smith.
And when I was in my regional role, I led the Ethnic Minority Action Plan for the Chief Nursing Officer, who has her own strategic plan, so that's nationally Ruth May. And Devon was very much, very active actually in that. And I think in any feedback we bring, Andrew, if we could bring both of those together, it would be great.
Thank you. I'm going to come to Sheena next, then Hisham, and I see that James and Liz would also like to come in.
Thank you. This is a really important area, but it's also a very complex one. And I think that there are different issues and different trends, and we need to be very aware of that complexity. So, for example, if we've got nurses and staff coming from abroad, you know, we're all aware of some very difficult structural issues, people not being able to bring their children in and stuff like that. We've got to be aware of that. There's absolutely no space in our system for microaggressions. What starts to worry me, and I'm putting my cards on the table here, I'm a first generation immigrant of mixed race, is when we start to talk about things like white privilege. It bothers me intensely because I find the lumping of all ethnic minority groups into one victim status deeply racist, actually. I really find it offensive. If we look at health outcomes at the moment, our biggest problem, most ethnic minority groups, with the exception of African Caribbean groups, are actually having better outcomes than white people. And that's particularly the case for white working class men, who have the worst outcomes of all. As somebody who apparently, of all of the outcomes, mixed white Asian have the best, and I'm lucky to have that. So why am I being lumped into this victim status when I don't feel like a victim at all? And I'm really, really worried about this, particularly in our coastal areas where we know that actually, in terms of health outcomes, it's our 3 generations of unemployed, white, commercial or military dock families that are not being served by our services well enough, who've got significantly higher standardised mortality rates, who've got significantly higher levels of morbidity. So we've just got to be really, really careful that when we talk about ethnic differences, we also recognise that white people can be suffering unequal outcomes. And I'm sort of saying that actually from a real point of view, I'm a huge fan of immigration for obvious reasons, because I feel I've been an asset to this country. I really am struggling, and it's from the best possible thing in my heart that I find it racist when we constantly look at ethnic minority people as victims. So just a bit of complexity here, please, folks.
Thank you for adding that that perspective, Sheena. I very appreciate that. Hisham.
Thank you, Chair. I just want to go back to what Tandy said at the beginning in terms of an action-based approach. And I think it's really important to recognize when it comes to race and ethnicity, they have multiple strands that, like a lot of colleagues have highlighted. There is the issue of cultural awareness and cultural competency, and Penny's referred to that. But there's also, as Tandy mentioned, the issue of variance in terms of health burden and health and disease presentation in different ethnic groups. And we know, for example, in some Asians, there is a high prevalence of type 2 diabetes mellitus. And that's just one example. Or sickle cell anemia in the African American ethnic minority. But given that differences as well, there is, and I go back to what Andrew said about the need for integration approach to this. In medical schools, we have 2 medical schools in the region, and they are already started in terms of the medical and clinical education. So that's one aspect. The second bit relates to how we train the workforce, including international medical graduates. So Andrew referred to nurses, but we actually have more international medical graduates in the UK, starting in foundation training, more than Holmes foundation doctors. And that's for the very first time been announced by the GMC. So we have a statutory duty to make sure that they have a level playing field in terms of preparedness for practice. And that's a patient safety issue, first and foremost. And then it's about equity of opportunities as well, and colleagues have touched on that. So my call is really for an integrated approach. It's not about giving privilege to one race or ethnicity, but it's about making sure that we do best for our patients by looking after our staff. Thank you.
Thank you. It's a really powerful point, Hisham. I'm going to come next to James McInnes.
Thank you, Chair. And could I just say I thought it was a great film. It's one of those films that makes you sort of really think and comes the heartstrings a little bit, and that's always an effective communication. As Chair of the Integrated Care Partnership, I really would encourage what Andrew said in terms of looking what other partners are doing as well, because I think we need a system response to this. This isn't just, trust NHS. This is, an integrated care board, and it's a system response. And I know there's a lot going on in local government in this area. I mean, I myself, as an elected member, have been through all sorts of training and like Penny said, it's actually quite wake-up call to what you don't think you're biased, but actually when you actually look into it, I do think about things a certain way. So I think a system response, if that was possible, would be better than for everybody.
Thank you. So on our action list that we have, that we're going to have a report on this, but we'll make sure that that is a whole system report rather than an entirely NHS focused one. Liz.
Thank you, Sarah. I just wanted to pick up a little bit about our role as leaders and our role as a board, and probably just want to reflect a little bit about my experience working in Torbay, because we've done a lot of work to think about particularly the international recruits coming into the organisation and how we really support really great integration of people into the overall ethos of what is Torbay and South Devon. And we thought we'd done quite well, and I'd been working with Sunita, and she's been mentoring me for a long period of time. And then we got our CQC report that told us that we weren't doing that well. And I think what it taught us as a board is the role that we have as leaders to set the right conditions and to be really clear about what we stand for as a leadership community. And we have, on the back of that, done a couple of things that I think have really been quite impactful. One is that we've signed a charter, and it's a charter in itself, but it starts with me. And I think there is just something about recognising our individual and collective accountability to lead on this and recognise our personal behaviour and the impact that has on people within your organisation, whether they're people who receive services or people who are providing them.
Thank you. It would be helpful to see a copy of the charter, I think, if colleagues would like to see that. Sheena.
Yeah, I just sort of wanted to come back on that because I think, again, what works and what doesn't. So if you're coming from a faraway place, you've left your family, you don't really know anybody within the area, you know, there are sort of things that we can do that are, I think, maybe paying lip service rather than the structural things like how can you get a house, how can you get a community, how can you be supported? And there are some really interesting kind of like, I think is it Home Start, where nurses from and other healthcare workers from who are migrating from other places can be placed within families. And it's a way of actually making housing, which is incredibly expensive around here, accessible to people, at the same time actually providing a family. I mean, often it's being placed with an older person, so there is sort of a two-way benefit. But I think there are things that we can do, and we should, you know, absolutely, but just kind of want us to be really specific about what the problem is and not just have this global thing that we have a problem with ethnicity. I don't want to problematise ethnicity. I want to celebrate it, you know.
Thank you, Sheena. I'm going to come to Nigel Aitchison.
Many thanks, Chair. Just to pick up on a bit on what Penny said. So at CQC, we spent a long time as individual executives exploring these issues for ourselves, including reverse mentoring and so on. And from a position where, like Penny, I thought I knew quite a lot about this, it turned out that I knew very little and I knew a bit more at the end. And then undertook a course which I think might speak to some of the opportunity that we have, because I kind of agree with Sheena. I think that actually there are opportunities through a presentation such as this that we need to exploit. And the course was called Equity by Design. And it was about how in almost any situation that we can think about, if you try and design for the people who traditionally might have found access to services more difficult, et cetera, then actually you end up benefiting absolutely everybody. So the example that Tandy talked about in terms of sickle cell disease, from my perspective, is a potential for epistemic injustice. I can never know what it's like to be somebody suffering from sickle cell disease. And therefore, reaching out and deeply listening and understanding what that experience is like and what services need to be like in terms of the responsiveness around a time of a crisis, for example, is the sort of approach that we should be taking for every service, for every person, and building that engagement. And in terms of colleagues coming from overseas, as Hisham said, our international medical graduates are now the most numerous compared even to our homegrown graduates. But I'll give you a small example of how this can impact. So there were a husband and wife doctors arrived during the pandemic, and she arrived first into a flat with no money, no phone, no kind of links to anybody, and spent 48 hours without any food whatsoever, just surviving on water until she managed to get that. And when her husband arrived, he'd been working on an intensive care unit in India, as it was. That's where they'd come from. And we know that there was a differential impact of COVID upon different ethnic minority groups. And he had looked after a number of people who had died, including his own father, on an intensive care unit, and was then asked, without any understanding whatsoever, to go and work on an intensive care unit. And his reaction to being asked to do that, Nobody could understand why he was reluctant to do that, but in fact it was because of his own experience that if somebody had just sat down and spent that time interacting as a person. So I think there are huge opportunities here for us, but I would highly commend to us as a board that we do undertake, with the support of colleagues, that deep understanding, because the world looks a very different place once you've had access to that.
Thank you. Tandy Hara.
Yes, so just coming back to Sheena's point about the complexity and the things we need to think about, I don't sort of try to present myself as representing, people like me, because actually there is an issue of class as well, even within ethnic minorities. And so although I had a child with sickle cell as the first one, maybe actually it was lucky that it was me that had it, because, you know, I was quite confident to talk to the consultants and say, let's sit down, let's do a protocol, and I don't think this is right. And we managed to put in a whole care plan for him that was then used for other children coming before him. But actually a different mother who maybe didn't have my background or my privilege or my confidence would not have been able to do that. So I think that when we talk of privilege, I do think there is such a thing as privilege, and I do think that I probably do have some privilege, say for my black skin, but actually there are other people who, in the same space as me, with black skin, without my privilege, actually struggle a lot, and they do fall in that category that you would call them as victims of the system. Whether they want to be called that or not is something different altogether. But I think we do need to recognise that the issue of class, and like you just said, class in both ends is quite difficult. But I think why we're struggling with this is, again, this pitching of us, them, or what about them kind of thing. If we see this as a whole, rather than it's race, and therefore if it's race, it can't be about class. It's class, and therefore it can't be as race. That's why we get ourselves completely tangled up.
Thank you. Really important point. I'm conscious we've got Ruth Harrell joining us online as well. And I just wondered, Ruth, if there's anything that you wanted to add as our public health member on this discussion.
Yeah, thank you. I mean, it's fantastic that we're having these discussions, isn't it? Because the fact that we're talking about it and are actively considering it is so very important. And the richness of the discussion, I think, does highlight the many different ways we need to look at this and the nuance with this, and absolutely agree with some of the statements made around, not grouping people together by whatever characteristic. And we know that's true in many different ways. When you look at any characteristic of an individual, you can't necessarily then conclude everything about that group of people, whether we're talking about ethnicity or whether we're talking about a particular disease. So we do know that, and there is that element of the importance of understanding individual situations and circumstances. And that said, despite that need to look at individuals, we also do see these trends that do reflect that for certain ethnicities, for certain groups of the population. And obviously, Sheena was talking about the deprivation and routine and manual workers, for example, as another category that are very important. We do see these trends, and we do have to understand it and understand how we can interpret that and how we can overcome that. And that does take us all to put in more effort, whether that's in understanding ourselves, whether it's in investing in services that are better tailored for those particular groups. So I don't think I can't add any, any one answer to any of these conundrums, but I think it's incredibly important, as you say, that we are turning over the stone and thinking about this and looking at it, and always questioning what is it that we can do further to reduce inequalities in whatever way those inequalities are showing.
Thank you. And I see that Frank Kelly, our partner for communities.
Thank you, Chair. I find this quite interesting because actually I'm also a first-generation immigrant. I've got Irish parents, and many people around this table are in a similar position. The issue for me is I have never been disadvantaged by that, largely because people can't tell it. And people in our society are disadvantaged for all sorts of different ways. It's not just about ethnicity. Often it's about opportunity. Often it's about where you've been brought up. And I think Sheena's points are well made. But I think systemically in Devon, we probably do have a culture of disadvantage. And the other point is, I quite liked what Penny did, was change it from an ethnic minority to a global majority. Framing things matters, and perhaps we ought to start thinking like that. But for me, the issue in Devon is disadvantage, and it is in all our populations, and we need to think of it like that.
Thank you, Frank. I'd just like to add as well, it's not just about outcomes, it's about access and experience. That's what we're tasked with as an ICB. And I'd also like us to think about how do we know? So we've done a huge amount of work, as has already been pointed out, on actually examining the background and demonstrating that there are issues, both for our staff and our communities. But how do we know that we're making a difference, I think is something I just wonder whether any of colleagues would like to comment on, come back on. No, Penny.
I'm going to talk about staff again, and of course staff do form part of our population. But one of the things we need to do, and are probably doing, I need to work closer with Andrew to fully understand, but really understand things like the disparity ratios, because that, and we often talk about people either, whatever the terminology, and of course that's difficult too, so for the purposes of now I'll call it global majority. We tend to focus on people who are internationally educated, but we mustn't neglect the concrete ceiling that people are experiencing who are second, third generation and who are well experienced but still not succeeding in their career for whatever reason. So I think there's something concrete we can do around sort of fair recruitment processes, and I know that we've been doing a lot of work on that, but really keeping an eye on our workforce metrics is one tangible way that we can take it forward. But there will be other success measures, and I think that's a challenge, Sarah, that we should probably look further at. But
thank you, and we have an important item later on our clinical care professional leadership framework, and I think it's something we could consider further in that section. So thank you very much, colleagues, and thank you in particular to Tandy. Thank you for your part in the video. I'm going to come next to our section on our leadership reports. I'm going to take my chair's report as read, and also just before we come to the Chief Executive's report, say thank you very much, Bill Shields, for everything that you have done, leading us as our interim Chief Executive Officer. But anyway, I wonder if there are any points you would like to make on your report.
Thank you. Thanks very much. It's been a privilege leading NHS Devon through the winter and through what I think is a really challenging period in this organisation's history, really. And I think the first thing is, in terms of the report, which I will take as read, relates to the system pressures. We continue to see significant system pressures across the whole of Devon. We were back in a very, very difficult position through the weekend. We had to stand up cold calls again yesterday. And we continue to see those pressures, and Sam highlighted some of the UEC difficulties that we've got, and it really does continue to be something that bedevils this system. We have had a huge amount of intensive support from regional and national colleagues, and we really do need to get this right, because the position continues to be something that is not good enough, doesn't represent high quality care or patient safety for the population and the patients that we serve across Devon. And so it's one of the major parts of focus, I think, that we will continue to look at through the System Recovery Board, through the Unscheduled Care Board, and also in discussions with regional and national colleagues. And I expect this to be something, along with our financial position, that's highlighted in those discussions, particularly as it relates to the NOF4 exit criteria. Second thing I'd like to talk about is the establishment of the Executive Committee. So with the board's approval, we established formally an Executive Committee. Prior to that being established, there was a senior executive team which met quite informally on a weekly basis. What we now do is meet fortnightly as an executive committee that has appropriate terms of reference which have been signed off by the board, and which allows us to transact business on behalf of the board, and then each other week we meet informally to go through executive issues and be able to understand where the organisation is and to provide the leadership that's required. I won't go through all of the things that we have discussed. The one thing I would like to highlight, because I know it's a cause for concern, quite rightly, is organisational change. We have gone through the phase 1 process. As colleagues will be aware, we have appointed 17 of the 27 posts. We are working through the contingency arrangements in terms of ensuring that we can be assured about business as usual. that we can continue to deliver those things that we need to during this period. And one example will be Piers here as the acting Chief People Officer, and that's one of the things that we're looking at in terms of ensuring that we have a full complement of executive directors, but also in terms of the director portfolios below that, that we can fulfil those. Each of the directors is now going through a process with myself and with Human Resources to ensure that we can meet the envelopes, the financial envelopes that have been determined to ensure that we can reduce running costs by 30%. That is a really difficult challenge. I am confident that through a process of negotiation with directors that we will get to the end point. We are being as flexible as we possibly can be. So we have taken into account the vacancies that we've currently got. We have been really clear about the income levels that we have to make sure that there's flexibility within each of those budgetary constraints, and we will meet the target level reduction. That is very difficult because we continue to be in NOR4, we continue to be subject to the highest level of scrutiny from NHS England, but it's something that unfortunately is non-negotiable, and we have to deliver against that target. Final thing I'd like to say is the fact that we are now in a new office, new offices. I think that the feedback that we've had from staff has been very, very positive. Apart from one or two teething problems with IT, I think we would, and heating, I think we would all say that this is a marked improvement from where we were before, particularly County Hall. We have the whole team together, and I really do think that we're starting to get a real sense of NHS Devon being a single organisation. People are much more present in the offices. We see significant numbers of people on a daily basis, and we really are starting to get a real buzz, I think, about working in this organisation. That's the final thing I would just want to add really is on the staff survey results. We have seen an early draft of those. We will digest those and then at an appropriate time share those with the board, and there will be an appropriate action plan that we will take forward based on the results that we've seen. Quite clearly, we have undertaken a staff survey at a very difficult time for this organisation, and we've done that during a period where there's a lot of uncertainty, where we're going through organisational change, and so I would just like the board to understand that will be a factor in the survey results that we've seen. We do have a lot of people working for us that are very concerned for the future. We are trying to ensure that that uncertainty is minimised, but it is a very, very difficult period, and that will be seen in the staff survey results. So a bit of a spoiler alert there, but don't expect it to be fantastic. There are some issues that we are aware of and will have to deal with. Thank you.
Thank you very much, Bill. I can see that Sheena Asthana would like to come in first.
Thanks very much. It's great to see there's good progress in key areas. It's just a wider question. When you are pursuing certain performance management targets, there's always that sort of risk of unintended consequences, that things that are not under that target get sort of left out or undermined. So are we keeping a good eye on some of the unintended consequences by, I mean, I know we're chasing some fairly big generic things, but, you know, are we aware of the fact that there may be losses as well as gains within the broader system in terms of things that we're not measuring? And I suppose an example of that, and also how, so I was really struck by a recent finding, I think from the north of England, that suggested that virtual wards were not actually cost effective. And I suspect that the extent to which a virtual ward can actually deliver effectiveness and cost effectiveness would vary by degree of digital maturity and interoperability. So if you've kind of got an EPR and you can start to link your data from the home, etc., then it possibly is, you know, I mean, I'm a great fan of digital innovation, but if you're effectively talking about hospital at home and you've got nurses having to go and do measurements, I can't see why that's cost effective. So I suppose it's another example of a sort of top-down target, which may not actually be in our interest with regard to effectiveness and cost effectiveness. And are we monitoring those sorts of, you know, positives and as well as the negatives? Because I think we're always chasing the positives because we're told to look at certain things, but there may be things that actually are going to bite us later on.
So if I could just respond to that specific point, I would share a number of your concerns. Virtual wards have to be more than hospital at home, and I think in some cases become synonymous with that concept. I think in the north and east of Devon, because we have a digital EPR, it's much more the case that they're collecting data, and those data are coming from wearables and from other things that can connect to Epic through MyCare. I think elsewhere in Devon, that's less the case. Myself and the Chief Operating Officer have had a discussion with our digital partner about how we can actually ensure that that's rolled out in those areas in South and West Devon and in Torbay, where we haven't got a digital EPR and where we're unlikely to have that for the next couple of years. I think it's important that we're really curious about the data that we collect. So when we look at the virtual ward data, it's not just a focus on the occupancy level or the number of wards, a number of beds rather, but also in terms of length of stay. So in some cases, length of stay in virtual wards is significantly greater than in actual beds, in which case, how is that efficient? So we really need to go and delve into the data that we collect and not just look at the headline target. I think that's absolutely right, and I think that's a really good point.
Judy Hargaden.
I just want to add to Sarah's thank you to Bill. I think you've stepped up. I've seen it mostly through the organisational change in an incredibly impressive way. Being the interim chief exec in an organisation going through what we're going through was always going to be a massive challenge. And I just thought that, you know, I often hear people, I talk with people about how well you've done it, and I thought we should just say that.
Thank you very much, Judy. Tandy Hara.
Yeah, I think this is a question I should have asked when we were discussing the not for item, but I'll be cheeky and ask it anyway. So just looking at that item, there's a list there about the domains for mechanisms for exiting not for, about 6 of them. And then I was looking at the list of the work streams that are in place, and I thought they're sort of not mirroring each other perfectly. In particular, the health inequalities, I'm not seeing it on the work streams, and I just wondered if there's a reason for that. Because I thought if that's the mechanism for exiting not for, then the key work streams need to.
I think it's a good point. The focus in the North Ford discussions, and we had one as recently as 2 weeks ago in the System Improvement Assurance Group, have been on unscheduled care, elective care, the financial position, strategy and leadership. Those have been the focuses. Clearly health inequalities is something that we need to focus on as one of our priorities, but at this time it's been very difficult for us to focus on that as well as all of the other things that we need to achieve in order to exit. We will be ensuring that through the restructure, that when we put in place the director level posts that report into the chief officer posts, that there is someone who has that as a key responsibility. And we can see that particularly in a number of areas in terms of the children and young people agenda, which we know we've got to focus on quite significantly, and in other parts of the services that we provide. So it will be a focus, but we need to get the team and the right people in place to make sure that we can take that forward effectively.
Okay, I just wondered whether that would then affect, if we get out at all, if it's specifically mentioned in the not for mechanisms, but yeah, take a point.
Alison Williams would like to come back on that.
Thank you. If I could just come back and clarify, Tandy, those are the software domains that are nationally determined, and then the region make an assessment of all of the organisations against those domains. The Preventing Ill Health and Reducing Inequalities domain is the one where the assessment is probably not as mature yet as the other domains. Because I'm not sure that there are very clear metrics yet nationally that individual organisations and systems can be measured against. So the exit criteria and the areas for improvement that have been identified by region and the national team in categorising the system as being in not for. So those areas that Bill referenced, which are the UEC, the elective, the finance, the leadership and strategy, are the areas that have been identified by those external bodies as being the current areas for improvement in Devon. It doesn't mean to say that preventing ill health and reducing inequalities isn't important and isn't a core part of the business. But those exit criteria have been set with the national team. I expect as time goes on, that will become more sort of prevalent in the assessment of everybody's performance. But I suspect it's just a reflection at the moment of there not being clearly agreed national metrics against which everybody can be measured at this point in time.
Yeah, I think that assures me now, because it means we're not going to completely expose ourselves if there isn't that assessment in that sort of sense. So, yeah.
But I think coming back to Sheena's point, which I think is, in a nutshell, that do we risk ignoring other really important agendas if the only thing we're assessed on is our NOF4 criteria? And I think as a board, we have already made it clear that children's services, for example, and the challenges that we face across our neurodiversity pathways, speech and language therapy, for example, that we're determined as a board that we're not going to ignore those really important priorities. But getting out a NOF4 will undoubtedly give us more flexibility to be able to deal with a wider range of issues. I mean, looking at things like, for example, challenges facing our hospices, dentistry, there's a very long list where we'd like to have more flexibilities, but we don't currently have those as a NOF4 system. Thank you, Bill.
Can I just come back on that? So I think that it's really important. I was having a conversation yesterday with the regional director when we talk about NOF4, that it's not a thing. The reason that we're in NOF4 is because our unscheduled care performance is amongst the worst, if not the worst, in the NHS, and that's really bad for patients. That's really bad for those individuals who've waited in the back of an ambulance on a forecourt or who've waited in an ED department for care to be provided. It's because our financial position is again amongst the worst, and that means that it's difficult for us to engage in anything in terms of long-term planning because we're always engaged in short-term firefighting. It's because we haven't had a clear strategy for healthcare, for clinical services in Devon, and without that we can't get the optimal configuration of services across the system. So I would just like to be really clear that when we talk about NOF4, it isn't a thing, it's an assessment of our performance and our success, which is something that we need to really focus on.
Thank you. Yes, Frank Kelly.
I just like to add my public thanks to Bill for giving us that level of focus, because I think it is important. I know I spend my time at the board wittering on about things like culture, disadvantage, health inequalities and all the rest of it, and I will continue to do that, but I do really appreciate the fact we now are in a position where we're seeing the green shoots of recovery that we've discussed earlier today, that we can gradually move to focusing on those things as well. So thank you.
Thank you very much, everyone. So if we could note both of those reports, and then we're going to come on to our section on the clinical and care professional leadership framework, and Nigel Aitchison is going to lead on this discussion.
Many thanks indeed, Chair. So we've been joined by our colleague John Taylor, who has been leading on the development of this piece of work over a long period of time now, and we're very pleased to present what is an interim report, and we'll explain why it's important for us to do that at this stage, and what our plan then is for this work going forward. So John, thank you very much indeed for joining us, and to colleagues, you've got the paper obviously in the pack.
Thank you, Nigel, and I'll just provide a bit of background to the item. So in May 22, the ICS Executive Group approved our One Devon Clinical and Professional Leadership Framework, and that was in response to a national mandate to for all ICSs to implement a new model of distributed clinical and professional leadership. Our framework outlined the vision for clinical and professional leadership in Devon, and also how it set out how we would embed the ICS or the national principles within our ICS operating model. The framework also provides the context for NHS Devon's developmental and leadership role in the system for clinical and professional leadership. For example, it sets out the function of our clinical and professional cabinet and some of the supporting groups. Although nearly 2 years on, the vision remains very consistent due to some national developments and some the evolution of our local system. there is, and specifically the need for the ICB to reduce its running costs and the need for us to identify clinical leadership to support some of the system recovery activities. We need to adjust our approach slightly to take account of the parameters that we're now working in and the current challenges that we've got. So therefore, last year, the System Management Executive in August initiated a refresh of our framework. Plan was to complete this over the autumn and the winter. However, due to the pressures over winter and the need to focus on system recovery activities, the full ICS update has been paused until later in the year. From an ICS perspective, this gives us a bit more time for engagement to ensure that the framework is really co-produced with our clinical leaders. It also means that our incoming Chief Executive will be able to influence the model and also really participate directly in some of the engagement with the clinical and professional leaders that we intend to do later in the year. However, since the framework also provides a shorter term context for some of the system developments that we're involved in now, and for example, the NHS Devon's internal reorganisation, we're recommending today that the board adopts an interim framework document, which is included in the pack as Appendix A. The key differences between the current framework and the proposed document that you've got today is the proposed document better aligns with our Phase 1 structures. It recognises the evolving leadership of provider collaboratives in our system. It provides further detail on NHS Devon's leadership role within the quality and safety arena. It also takes account of ongoing work to develop a general practice and ultimately a primary care provider collaborative in Devon. So you've got the recommendation, and what we're asking the board to do is adopt this interim framework until we do the full update later in the year. So happy to take any questions.
Thank you very much. I see Liz Davenport would like to come in first.
Less a question, I have to say it was a really great paper and I really welcomed it, and I think we're already seeing the benefits of how we work through dispersed leadership models, for example through the Peninsula Acute Provider Collaborative, where we brought clinical leaders together to really shape the future of services, which has been really positive. I'm also very keen that we've got a strong focus, and it's not at all because I'm an occupational therapist, to see us looking at diverse leadership, and I do think we have to challenge ourselves to ensure that we bring a broad range of clinical leaders through these sort of programmes and really create opportunities for people to grow their careers. And I'm certainly very involved in doing some work nationally that really seeks to promote it. I suppose my question is more about, this is a change in culture, it's a change in a way in which we work, and they're just wanting to understand a little bit more about how we will support the change in practice in this collaborative approach that's promoted within this model.
Many thanks indeed, Liz. So a great question, and I think there are two parts to this. So one of them, so Penny and I would have, in the old construct of the cabinet, have been the co-chairs. What we've very deliberately done is we've said that'll be a three-way co-chairing with a colleague actually from local authority. So it speaks to the multi-system approach we want to take, and in fact the colleagues are who wanted to express an interest in that are AHPs by background. Of course, we are really fortunate in Devon to have the AHP faculty, which is a fantastic sort of group and opportunity for us to really build and link into what is I'm sure you know a group who are doing fantastic work. So that's very definitely part of our planning. The second bit of it, though, and I think it speaks to this is doing different things. We are really keen through that dispersed clinical and care professional leadership right across our system. Diana Crump, who's the current chair of the VCSE Assembly, for example, is a core member of the leadership group of the cabinet. So opening up new opportunities, but that will take deliberate, supported development right across that leadership space in the system. And as you know, we have started some of that work, and we will need to think how we support this clinical and care professional leadership system development as part of that, in order to get the maximum benefit from the opportunities that we have. But huge opportunities in this space that John has so carefully helped us to create, articulate. Penny's team around safety and quality, what that looks like in this new space. It's been already a multi-professional, multi-kind of system construct.
Thank you. Just following on from that, of course, since the original document, we've taken on responsibility for pharmacy, optometry and dentistry, very importantly. Are you able just to assure us that those areas will be fully represented?
Yeah, so as John said, this was always intended not to be a medical or indeed just purely nursing construct in terms of clinical and care professional leadership. And right from the moment we started this work, it was very clear that what we wanted to do was to open up these opportunities and indeed to identify those areas that we need as a system to develop. So in terms of dentistry in particular, in terms of our restructure, we're working very closely with John and Anthony in the Operations Directorate in terms of what that would look like as we develop the approach that's been given to us or delegated to us through the pharmacy, optometry and dentistry delegation. And one of those key areas will clearly be how we source and access clinical dental advice as part of that work. Now, we've been very fortunate in that there are regional colleagues who are advising us currently, but we, of course, will try and build that into our local system, clinical and care professional leadership and the linkages. And I know Frank, for example, has been attending the local dental committee meetings, local optometry meetings. So we're beginning to make some of those relationships, but we will need to build those into our formal leadership.
Thank you. And I know that Sheena has a question, and then Alison, I'll bring you in next maybe to respond to all of those. Thank you.
Thanks very much. This is really interesting. I suppose I've got three questions. If our kind of clinical and care professionals are to drive change, are there tensions between... do we need to ask questions about their ability to do so within a broader management structure, which, again, I'm sorry, comes back to performance management and targets and perhaps things that reduce people's autonomy? And are we really looking into that and where our freedoms and flexibilities lie? So it's just a kind of concern, because I do think there are tensions between management and clinical autonomy. The second is that brilliant to hear that Frank's been talking to the ophthalmologists and the pharmacists, but the kind of way in which we've set out our provider collaboratives are very much around professions. They're sort of siloed professions. Whereas actually what we probably want to do for the future is to start working much more in a multidisciplinary team way, and really sorting out those care pathways in terms of what's the most effective way of people doing that. So are we missing a trick here in terms of really setting up our collaboratives in slightly different ways, which can reflect the overall care pathway rather than what doctors do and what nurses do, and you know what I mean? I don't know. But the third one is about the research, and conflict of interest here. I worry, I think I absolutely agree that research can play an important role in driving innovation. I worry that as a system we tend to look to the same old partners. So I'm constantly hearing about the University of Exeter, constantly hearing about the Health Innovation Southwest. As someone who's at Plymouth, I'm kind of, hello, we do some good stuff too. And I just wonder if we are being careful enough to look at the way in which we are investing in research and drawing on our local excellence, because it's not a case of levelling up, perhaps it's a case of equality in the way in which we're doing this.
Nigel, did you want to respond to that?
So in terms of the collaboratives, I mean, it's really interesting because I don't recognise in terms of our ambition for the collaboratives that they are single kind of clinical focus at all. And certainly in what are very early conversations with colleagues in primary care, they're already talking about actually this needs to cover the whole of the workforce in primary care, which, as we know, is rapidly expanding and evolving. And I think that's true also of the mental health provider collaborative already. It's a bit more advanced in its construct, and we're already talking in the acute provider collaborative space about how we bring some of that together. So I think that will be an evolution that we'll see. The research question is really, really interesting, and I, for one, I love a lot of the work that's going on in Plymouth. I don't forget Plymouth at all. I think that we need to draw upon all of the opportunities that we've got within our system and indeed partners more broadly. The construct that we are linked into and we're part of course, is Health Innovation Southwest, the former AHSN. And I was reflecting with their chair earlier this week about just how we draw that partnership together, because each of our universities are like ourselves, colleagues in Somerset ICB and Cornwall Isles of Scilly ICB, members of that construct, and how we make that work for us, I think, is a really important area. In the area of research and innovation for colleagues across that clinical and care professional leadership group, I think it's really important that we give opportunities at all levels and across all disciplines. I mean, it's certainly something that in my clinical career was something I not only enjoyed, but I think that was valuable not just to me, the departments, the universities, but also patients. And I think that we are not exploiting nearly enough some of those research opportunities, many of which directly benefit patients who are participating. So that is an active conversation, and I think what you allude to is the fact we haven't got that right yet between us. But that is certainly a commitment as part of that group.
Thank you. Thank you, Chair. I think what's really important is to look at how the clinical workforce and the clinical and professional workforce is a huge asset to support the board in its endeavours. And the trick is how you draw on that to support the whole business of what the ICB does. And it's not just about the clinical voices that are around this table, but it's about how in discharging all of the business, both strategically and operationally, there is that assurance that the clinical and professional body are being constantly drawn upon and used to support the work. I think a mature board will probably find that you're bringing more clinical and professional voices into the room on an issue-by-issue basis to help to enrich the debate and the decision-making. And I think that as these structures bed in, how particularly the clinical and care cabinet is its relationship with this board and how that expertise is used will really enrich the way that you do your business. And if I may just come back to the point that you made, Sheena, I think that historically I have recognised as both a clinician and a manager in the NHS that where you really get it right, the clinical leadership and the managerial leadership are absolutely on the same page, so that the clinical leaders are as conscious about the need to live within the financial means, to get best value and to meet the targets, as the managers are concerned about the quality of care and the clinical outcomes. So a mature system where everybody grows together and is pulling against the same outcomes that they're trying to deliver means that you don't have that tension, but you have to recognise that that requires a lot of development for people along their journey. And the final thing that I would say is that time to lead for clinicians is probably one of the biggest challenges that the NHS faces. Ironically, for consultants, you can build it into their job plans, but for primary care and for non-doctor professionals, creating that space in their working week so that they can contribute to the leadership agenda is something there's probably going to have to be a conscious thought about how that is done in the future. And I'm afraid to say there is a cost associated with that, but there's also a value associated with that, and it's about how the system balances that. So it's complex, but this is a really good start. The trick now is how this board uses the asset and the opportunity that you're creating through these arrangements.
Thank you, and that's very much going to be built into our governance review. Thank you, John. Did you want to come back on that?
Just wanted to come back on
Penny?
a couple of points, if I can, please. I think, as Alison just said, I think she probably touched on the most important and most challenging thing to consider within the context of this. It's how we actually draw out those clinical and professional leaders at all levels as well, at a specialty level, an organisational level and a system level, to support the many priorities that we've got at the moment. And I think we need to articulate that as we go forward. Just to come back to Sheena's point briefly on the professional categories and the potential silos, I agree with Nigel on the provider collaboratives, but I think we have got an awareness of that in the model, because if you look at the arrangements that are starting to emerge, for example, the AHP model and other models like that we might want to set up around professions, it is really important to strike a balance between those professional groups and then getting everybody together to work together as a multidisciplinary group. We've tried to strike that balance with at the moment, with some of the arrangements we've put in around I think what we've referred to as either a reference group or a community of practice, which is much broader and has full professional representation on it.
Thank you. And then finally, I'm going to come to Penny Smith.
Thank you, Chair. So Alison and John have made a number of the points, and I think particularly that element of job planning, some structural barriers for all of the clinical and care professions to engage. And I really want to emphasise also, Alison, that point around the pull that this board can have in making this jump from a paper into practice. But the opportunities, I'm so passionate about clinical care professional leadership because it's truly multi-agency and it really plays to the partnership gains. But we had, in the Southwest, we had a nurse and an AHP who were authors of the national guidance. So, it'd be very interesting to pull them into this space to see how they've taken it forward in their own systems, for example. But I think for me it's about how we implement this now, and we've got an opportunity with our current change process, and the gain will be in those multidisciplinary approaches. So really to commend the paper and to encourage the board to keep inquiring and use the arrangement.
Thank you, and I'm very conscious of time, and I'm going to seek the board's approval for this this document. But Judy, did you have a quick point you wanted to make?
Quick point picking on the point Alison made. The best led systems are where clinical leaders and people who are leaders but don't have a clinical background work together well. So let's make sure we develop these in parallel, and perhaps we can come back to, at some point, what we're doing around the leadership development of the non-clinical people, non-care professionals, so that we create this wonderful harmony at the top around decision.
Thank you. Very important point. So can I ask for the board's approval? Any objections? So thank you very much. If we could note that, Philippa. Right, we're going to come on now to our Integrated Quality Performance and Finance report, and very grateful to John Finn for leading on this part of the discussion.
Okay, thank you, Chair. I'll just go over the key highlights points in each of the sections, actually, and then take any challenges or questions. We look to elective care, actually, in terms of we have reported 7 patients still waiting over 104 weeks for treatment against a plan of 1 for December. That's absolutely down to the impacts of industrial action, actually, and the impacts of industrial action across the wider elective programme. In terms of 78 weeks, we're a bit behind. We're a bit behind trajectory, but we are working to improve that and will improve that by the end of this financial year. So there are sections in terms of Torbay and Plymouth Community Diagnostic Centres, which are a key part of our strategy going forward. The Torbay unit will be operational circa July 24, Plymouth 25. In the interim, actually, there's additional CT capacity ahead of these completions in both Plymouth and Newton Abbot. The second phase of the Exeter CDC isn't due to completion for July 24. Really importantly, in terms of endoscopy capacity, which has been a huge challenge for us as a system for many years, the Plymouth additional capital build is progressing to open in April 24. This was previously meant to be in place by January. We've had to decant into a Vanguard unit to bring up that capacity. There's some really important outcomes of that work. Actually, the plan around endoscopy started actually in 21-22, showing the importance of long-term planning. But as a result of these capital bills, actually, we'll meet the DMO1 for endoscopy for RDU and Torbay in the first quarter next year, and for UHP in the second quarter. That is not a long road to that. Also, the additional capacity we put in through these capital bills will give us sufficient space to be self-sufficient outside of the independent sector until 27-28. The shown long-term plan starting in 2021, really starting to bear fruit now. In terms of, cancer, I think it's important to highlight some real positives in the Devon system as well, actually. In terms of in the Wider report, you'll see the progress we made in the 28-day faster diagnostic performance in cancer. It's really good to have Liz beside us actually in terms of her trust has achieved this 11 months in a row, and just a little bit of fine tuning in terms of validation to make that 12, and that will be the best performance across England. And being the only trust to actually achieve that. In terms of urgent and emergency care, the dial is moving very, very slowly in this, as everyone on the board will know. We have seen some improvements in terms of the metrics, basically, but not sufficient in order to bring us to where we need to be to balance the challenges of urgent care and elective care. Our Category 2 response times, unfortunately, got worse in December, with an average response time of 53 minutes from 47 in November. The actions in the paper in terms of urgent emergency care actually are there to manage the Devon system actually, and they have resulted in Devon ICB remain the lowest quartile national ED attendances per 1,000 population. That's not reflected in the operational challenges that we're seeing at this moment in time. In terms of hospital discharge, huge amount of focus on this over years actually now. The two things we measure are no creditor to reside and length of stay. The Devon target was set through an off-4 process actually for 5% no creditor to reside. By December we were achieving 12. But it's important to understand some of the nuances that in some of the real challenged areas. While last week we had 5.9% in terms of for Plymouth and Devon patients for the UHP system, it was actually 17 for Cornwall. Now I know Kate's not here today, but I do think there has been a request for some support in that area on numerous occasions. I think it's important that we do pick it up with our stakeholders. That's a significant driver to the pressures in UHP. We continue to focus on length of stay. So some of the decrease in volumes of 14 plus days we were seeing in the last quarter, unfortunately, were reversed through December, but we are showing signs of improvement. And also in terms of the ops plan for this year, most of the length of stay work has been post-fit for discharge. We're also looking at the internal performance metrics that can be done to reduce length of stay. As a primary community care, we see the 3 out of the 4 access targets for GP appointments, and currently the waiting list, almost 30,000 in community, basically shows some improvement. But I said a lot of work to be done there. In terms of mental health, we've 7 long-term plan indicators and 6 additional key performance indicators. For the long-term plan indicators, we continue to improve, but we're not quite achieving those targets. In terms of talking therapies, in terms of the monthly access and the rolling quarter, again, not achieving where we need to be. I think through the Mental Health and Learning Disability Collaborative, we're actually a lot of good actions, well structured and well managed actually to reduce the risk actually that increased demands actually have an impact on waiting times. I think it's important to remember in terms of this area actually that there's a recognised gap in Devon and across the country basically that some patients they're too complex for the IAPT talking therapies but not complex enough for our community services. So we've been doing a bit of work to in terms of some of the counselling contracts that are available through the collaborative, they reviewed and stood down to focus on that gap in service, which will improve this performance matrix. In terms of dementia diagnostic rates, actually, it's again a very stubborn position for many years across Devon. There was a dementia summit in this office about 2 weeks ago to help to define the priorities and actions that will help improve this. Actually, we should see the impact of that in the coming quarters. In terms of the annual health checks for people with learning disabilities, there's been huge growth in this area over the last 6 months, which has absolutely impacted on our ability to achieve this. Actually, recognising that there's some SDF funded pilots working with PCNs and the voluntary sector to support individuals who are particularly challenged in actually accessing these services, and also work to align these health checks with other health checks such as antipsychotic monitoring and eating disorders to maximise what we achieve here. In terms of children and young people, the 2 metrics that we report on are autism diagnosis and speech and language therapy. Again, a long way from where we need to be here. Positively, in terms of the Devon Investment Group, which our Chief Executive chaired this week, actually, I think approximately a quarter of the bids actually went through for investment are in this area. So there's a dedicated opportunity and willingness to invest to move this agenda forward. That, of course, will be subject to the prioritisation of those bids and agreeing those. I think the quality, workforce and finance parts of the report are clear in the report. So I'll see Sarah and take any questions or challenges.
Thank you very much, John. Would anyone like to come in? Sheena, Sana and Frank.
Thanks very much for that. That was really interesting. I have a question about children and young people's services, a couple of them. So are we any closer to finding out waiting lists for CAMS? So I appreciate we've got the autism and the speech and language therapy, but I think a lot of us are quite worried about CAMS. And my second question is as I'm guessing that waiting lists for CAMS are probably growing like the other ones are, have we thought about alternative approaches to service provision? Because we're talking about staff capacity. There are some really interesting digital offers out there. So there's I think there's a Lancashire outfit started from a GP who does kind of CAMS therapy online. And I think younger people are more used to digital and reaching out. And I'm just kind of wondering if we should start to be a bit more proactive about this, because the waiting lists are terrible.
To maximise the use of digital projects is a priority. To be honest, I couldn't answer the question in terms of what we're currently doing actually, but happy to take that as an action for myself and to come back to you directly. But in terms of the waiting list, I really understood, and again I think through the collaborative again actually that's our mechanism for I think a slightly different approach in terms of how we address those. Begin to bear fruit, but not impacting yet on the
If you want,
on the
I can give you the name of this particular provider, and I don't know anything about whether, but I think they have been nationally accredited. The issue about CAMS is that these weights are really critical because of the fact that they're children, they're developing, it's just so important in terms of their future health outcomes that we get this right as soon as we possibly can.
Question.
Online.
A lot of interest in coming in here. So what I'm going to do is take questions and then ask if any of our exec team would like to respond to them. Frank, and I know that Judy Harkerton would like to come. So Frank O'Kelly first.
Thank you. So 2 points. One, the cancer stuff is great, but I think there is a very slight risk of us losing data. 2-week waits disappeared in November, and what we're reporting is a percentage, and I don't quite know how at the hospital end these are getting recorded at this point. So could we have numbers reported as well as percentages, so we don't suddenly see we're dropping in terms of the numbers? Percentage could stay the same and be really good. The second point is, if we're going to focus on children and young people, could we move to having the same sort of discipline about 2-year waits, 78-week waits, and all the rest of it? And that level of focus, I think, will drive us to deal with it differently, because Plymouth average is 90 weeks for autism and ADHD. How many 2-year waits have we had? And as a percentage of that child's life, 2 years is a very, very long time.
So on the first question, in terms of the 2-week waits, those are still counted and focused on every day, and it's just this not part of the national reporting programme. But certainly they're part of that 28-day standard. But I said if you wanted to review those, we can obviously do that. But I said they're not part of national reporting at this time. In terms of waiting, we do understand our waiting times for our community service, children's services. Actually, it's an interesting point of whether I think seeing them in the same light as 104 and 78 would impact actually. So perhaps that's something we could discuss outside of this. I don't think that would be a huge piece of BI to undertake that. It's just what's the management excellent clinical action on that data that we need to agree on.
Now I know that Liz wanted to come in and Judy, so Liz first.
So my question was, or kind of observation, probably linked to children and young people services as well, because I think what I know from providing the services, but also what's been highlighted in the report, is that we've got significant workforce challenges in terms of the number of vacancies. And although we're seeing some improvement, there is a broader strategic workforce risk here, not just in this part of the country but elsewhere, that we need to be able to respond to. And even if we were able to recruit, we know that we've also got a gap in terms of capacity against the demand profile that we're seeing. I absolutely agree with Sheena's point around the use of digital. It does form part of our contract, and we do have digital platforms, and we know for a cross-section of our young people it is a really acceptable way into services, which has been part of our broader conversation. There's more that we can do in that space. But we are seeing increasing demand, and I think actually on the media this morning there was significant coverage around the increase in demand for specialist CAM services. I do think we also need to think a bit more broadly about the whole system, and I've been really pleased by the work that we have been doing collectively over recent weeks and months around a broader system response to supporting health and well-being in our young people, so that we're intervening early, making sure that we've got the right strategies to support young people and their families, ensuring therefore we've got better capability of managing demand at the specialist end, because we can intervene early and minimise the risk of people requiring specialist services.
Thank you. I know that Judy would like to come in, and James, but I'd also comment that the work that we're doing with the VCSE, I think, is exceptionally important in supporting families while they're on the waiting list. And so thank you. Judy.
So I just wanted to highlight that I think this is children and young people services, speech and language therapy and autism is an absolutely classic area for the new models of care. We are just sitting on an old way of doing things and saying, oh, it's hard to recruit, and we need some workforce-led new models of care, different approaches, which might involve technology, but might involve a whole bunch of different professionals who don't take 6 years to train to make a difference here. And I find it worrying that we keep getting reports that say it's getting worse, it's getting worse. And the actions that are being taken are quite small actions and still in the old way of working. And, you know, necessity is the mother of invention. Necessity absolutely has to dominate the way we resolve this particular issue.
Thank you. Could I bring James McInnes in, Chair of the
Thank you,
One
Chair.
Devon Partnership?
As you know, because you were there, we had a good meeting of the Integrated Care Partnership last week in terms of children and young people. Very good presentations, both from NHS and local authority children's services. And it was clear from that meeting, and what Judy's just said, is that we'll never have enough people to actually deal with the system like it currently works. It just won't work. So we've got to look at new models of care. We've got to find ways of supporting children and their families before they get a diagnosis, not waiting for a diagnosis, because because the way the world is financially, manpower, the old system is just doomed. And so I really do encourage all the work that's going on with a new model of care. It's really, really important. And very much the Integrated Care Partnership with local authorities, NHS, and you mentioned the VCS, and I think it's really important that we have a more consistent approach how we work with the community voluntary sector. And one of the things, I know the Chair knows I've got a bit of a bee in my bonnet about this, but the way the NHS and local government actually interacts with the community voluntary service is all different all over the place. And it's really important for me at a high level that we have a consistent approach across the system so the VCS knows where it is and we know where we are. It would make so much more simple to actually engage with the community voluntary sector so we can actually support children and young people and their families in a better way.
Thank you, James. And I know that we're expecting a detailed report from the One Devon Partnership at a future board meeting. Now, I'm very conscious of time. We are behind time, so can I ask people to have questions or comments that are brief? I'm going to come to Tandy. I know that Alison would like to come in, and Nigel, I'm going to give you the last word. So, Tandy first.
Yeah, I think I was just going to add to that point of pre-diagnosis stage. I mean, if I am pre-diabetic, there's a whole range of things that I'm going to be told to do before to stop the diabetes from developing. I think what's happening with children in autism is that people think they're waiting, and that when they get a diagnosis, something will change. Often, when they get the diagnosis, they don't get anything anyway. So it's like, what was that wait for? So I think that if most of these children, if they're being referred by teachers and parents, a good number of them will be diagnosed with autism or ADHD anyway. So why don't we focus on providing a service to those children who are pre-diagnosis? And then the diagnosis, if it comes, it comes. If it doesn't come, it doesn't come.
Thank you. And as you'll know, that was a theme of the discussions that took place at the One Devon Partnership. So thank you for that. So right now to Alison and then finally to Nigel.
Just two quick suggestions, if I may, Chair. The debate about the children's service, clearly the board here is very keen that a new approach and a new model of care is developed. So where is that remitted to from this board so that that work is done and you get the answer back and you get the assurance that that new model of care has been developed? Is it the Mental Health Collaborative? I'm not sure where the place is, but I think it would be very helpful for this board to remit that and request that of the system. And you'd expect me to say that arguably the same needs to be done around urgent and emergency care. If you were to look at the biggest failing in this report at the moment in terms of the quality of care to patients, it's also about the differential urgent and emergency care performance. And should this board be remitting to the Finance and Performance Committee or elsewhere within your structures, a real deep dive organisation by organisation for them to be held to account for the actions that they need to be taking to improve the performance for your population. So just those two things, perhaps it would be helpful for this board to make a decision on remitting and requesting that work to be done.
Thank you, Alison. Could we add those to the action list, or Philippa, you would like to come back on that?
Thank you. Absolutely happy to add to the action list, but also to provide assurance that in the absence of the chair of the Finance and Performance Committee, we've been working up a work plan for these meetings, including deep dives on these issues, and I believe UEC is the next but one, so we'll work about how we can bring that into an earlier meeting.
Thanks, because just looking at this data, it's urgent.
Yeah, and sorry to also add, the Quality Committee is taking a deep dive on children and young people at its next meeting as well.
Thank you. And then finally to Nigel, because we really must then move on.
Thank you very much, Chair. Just very, very briefly. So I'll use ADHD as an example of a number of things. One of them is the extraordinary increase in demand, not just in this system, but across the country that we've seen in referrals since the pandemic. So that is a real factor. I think the other thing, as James said, the real opportunity here for proper system working, that's why we're in ICB, I think, and one of the big opportunities. So voluntary sector, local authority colleagues, Donna and colleagues in the other local authority areas, education, colleagues from the police service, all of them coming together to try and work on this agenda. But just getting back to the ADHD piece, so getting back to what colleagues have said, because of the dramatic increase in referrals, we do need a transformational approach. So in addition to the rigour and others have described, Bill bringing to us in terms of some of those programmes of work around what are we doing in specific areas like the increased referral to private providers and the risk of increased prescribing. We've got a dedicated piece of work that's coming together to try and manage that particular aspect. Obviously, in terms of some of the providers and recognising the challenges about what we're doing to try and clear those waiting lists that have emerged, but actually recognising that we do need a different approach, and it is that needs-based approach that we are working up a proposal and finalising. And in fact, as John said, a number of the bids that went to our Devon Investment Group that Bill chaired yesterday, there were some specifically around how we would approach this piece of work, which is to implement a needs-based approach, which hopefully will reduce the need for some of those assessments for a diagnosis, but because we're meeting the needs of those children at a much earlier and upstream stage. So just to reassure the board, there are specific actions, funded plans that we're taking forward.
Thank you. It would be helpful to have a summary of those in a future board meeting. Thank you. I'm going to come now to the section on our operational plan update, and for this we're again being asked for approval for the sign-off process, and it's Sam Wadham-Sharp's going to be leading on this piece. Thank you.
Thank you, Chair. Good morning again, everybody. So I'm going to try and walk us through our process for the 24-25 operating plan. I'll take the paper as read. However, this is a very fluid position at the moment, and therefore I will try and provide some more up-to-date information based on what has changed since the paper was written. To start with, I think it's important to recognise that we are currently creating a 24-25 operating plan in the absence of any national guidance. No national guidance has been published on operating plans, no templates have been published on operating plans, and they are not expected to arrive until after the next budget now. However, we're not allowing that to prevent us from getting on with doing what we need to do. We're very clear that many of our priorities for next year will remain the same as this year, particularly in the spaces around finance, UEC, elective recovery, but we will need to wait for the guidance on some of the more nuanced areas around operational planning. We've developed a new approach to planning this year, whereas last year we've taken some learning from last year's process. We started earlier, and I believe we're in a better place at this time of the year than we were last year. We've also decided to take a bottom-up approach. Last year we applied some very blanket and blunt instruments into our planning, such as our demand growth, our productivity basis around a 1% improvement, and also how we would treat some areas of our finance. So this year, we've created a bottom-up approach to look at what are the forecast outturn positions of each of our providers and the wider system on an activity, a performance and a financial basis. And then we've run several lock-ins around finance, UEC and elective to understand how do we then build in our areas of productivity, our system-wide financial schemes, and on top of what our current forecasted growth and activity would be, and where is the gap then between what that leaves us and where we would need to be next year, and that is a work in progress. We're also trying to make sure that workforce is a theme that runs throughout. Last year, I think one of our pieces of learning was that workforce was a bit of an afterthought and was left on its own. We're trying to make sure that they are fully briefed and guided on all of the outcomes around our finance, our UEC and our elective conversations, particularly to understand how workforce will be an enabler to what we need to achieve. So in terms of those lock-ins, there were three key aims to develop our plan this year. That was to get a system-wide agreement on the level of performance and financial ambition in the absence of the guidance and what we need to achieve. A system-wide agreement on the assumptions around growth. How do we treat ERF? How do we look at different areas of productivity such as GERFT and apply them at a system-wide level? And a system-wide agreement on how we will deliver those elements of the plan and who is responsible. The principles and the outcomes part of the paper remain pretty much the same. However, we have had a briefing in the absence of guidance on some of the certain factors that we will need to achieve next year, and we've built those into our lock-ins. So some of the key performance requirements for next year will be a 4-hour performance that is better than this year. Now, better than this year needs to be taken into the context that we are expected to hit 76% 4-hour performance by the end of March. So we are expecting that number to begin with an 8 next year. As I said earlier, in the NOF4 paper section, we are currently between 61 and 63% for our performance, so there is a long way to go there. A CAT2 response time that is better than this year. Again, we're expected to be at 30 minutes average response time by the end of the year. So that means it needs to be better than that, not better than where we are currently. Ambulance handover doesn't feature at the moment, but we know it is an enabler to both of these. So we will need to be looking at what are we doing around reducing the ambulance handover delays across our system as part of this plan. In terms of elective, we're expecting to receive a mandate for no 65-week waits at the end of the year. However, we also believe that will only be for H1. We expect there to be a revamp of that plan in H2, and that to move us to elimination of 52-week waits through the year. I believe this is achievable from what we've done this year, and the modelling shows us that we can really push for that. The cancer standards have already been announced in the press previously, and they will be what will be adopted into this year's plan. I think we need to be mindful that there will be a reintroduction of the 62-day cancer standard as it was originally. So that is 62 days to treat patients who are referred or upgraded on a cancer pathway with a positive diagnosis of cancer. We expect that not to return to the 85% standard, but to be somewhere in the low to mid-70s. At the moment, we're around 63% as a system. Whilst we have managed to clear the backlogs in our cancer pathways at the moment, we're not quite achieving where we need to be in terms of that factor, and that is something we'll have to build into our plan. There is some quite vague guidance around improving the access to primary care. We're not sure what those standards will be, but that'll be around the access to same-day appointments and appointments within 2 weeks. There is an improvement of access to mental health perinatal services and urgent and emergency care access, so we'll need to factor that in, and we've made sure that mental health have been included very much at the forefront within our UEC conversations. There is the need to submit a balanced financial plan, but that will be around year 2 of our medium-term financial plan, and what does that mean for us? And in terms of workforce, there is a requirement to reduce agency spend as a percentage not yet set. However, making sure that workforce is a theme that runs through our plan, I think we need to do something over and above that in terms of our pay bill and understanding how we best use the workforce that we have at our disposal to deliver the plans that we require this year. What we've agreed so far in terms of building the plan is that we will treat ERF recurrently. And that is the elective recovery fund, the amount of money that we get for certain levels of activity in our elective space, and we will use that to try and reduce the over-reliance that we have on insourcing and outsourcing, as we said earlier, and to really bolster the workforce in those particular areas. We will use getting it right first time and model hospital data as a main driver for us when we're looking at productivity. That is an agreement that we've had in both UEC and elective, and understanding what our ambitions are to get us from where we are now to either sustain where we are in upper quartile or push ourselves to upper quartile and make sure that we are as productive as we possibly can be. I've already said that workforce will be a thread through everything that we're doing, and making sure that we have, when I talk about workforce, significant clinical leadership at the forefront of all of these plans to make sure that they are properly embedded and clinically led. And also that we're going to look at how we've spent the monies that we've put into UEC. So taking the 13.8 million that's previously been signed off here that has gone in, we're going to treat that recurrently, but have a different way of looking at how we spend those monies. So we are making wider system decisions rather than just rolling over current schemes, being very clear around where we've had impact on investment, value for money, and what do we need to do next. As I've said, we expect there to be a gap between once we've built in the levels of productivity and the financial schemes, between where that gets us and where we will need to be in terms of our plan objectives for NOF4 exit, but also delivery of a proper operational plan. We'll then need to work out how do we bridge that gap. And that will be making sure that we're fully involving our chief executive colleagues within some of those key decisions, because it might mean that we have some difficult conversations to have. We need to make sure that we fully involve the local authority once we get to that first point of the baseline plan, particularly in our UEC space, understanding what the plans that our local authorities have and how that will impact on what we need to deliver, particularly in the out-of-hospital space. And then moving on to governance, there is a governance chart within the paper that remains the same. So Finance and Performance Committee will be where we will take the first cut of this plan. We need to recognise that the timeframes are very tight. We expect to have to submit a first cut of a plan on the 29th of February. That will require a review at Finance and Performance Committee on the 27th of February, but understanding that all of our providers will need to take any form of plan through their own sovereign boards within that time frame as well. We expect to have to submit the final, so we will get some feedback from Region on that plan on the 29th. We expect to understand already what the gaps will be between that plan and where we need to get to, so we will not just wait for that feedback, we will continue to work, but we will have to submit a final version of an operating plan on either the 21st or the 28th of March, and that will need to be reviewed here at a private board before it's submitted. So in terms of the paper and the update, I'm asking for approval of and adoption of the process for developing the 24 and 25 plan, particularly recognising the absence of national guidance and support in terms of the methodology that we're taking forward, rather than waiting for the guidance to arrive.
Thank you. It's extraordinary that you're having to do this without the national guidance, but there we are. That's how it is. And thank you for the work that you're doing to try and produce this without that being in place. Does anyone have any points they would like to make or questions they would like to ask? Yes, thank you very much, Graham Clark.
Well, I'm sure we're all round the table scratching our heads around the timings of this, because it's getting concertinaed. So I don't quite know how the board and finance and planning performance will fit into it. But putting that aside, can I make a different point? Not that you haven't got enough to do already. When this organisation and board was set up some, whatever it was, 18 months ago, we put quite a lot of effort into thinking about our strategic objectives, we had, if you remember, 4 themes and 14 objectives. We had the input from James and your committee to that, and we set ourselves a strategy. Now, we didn't in that strategy really think about the measurability of it or the timelines of it, but there is a strategic imperative for us, and then we've got an operational plan here. And at some point, I think we need to bring those together, because at the moment it's a sort of implicit assumption rather than explicit that this plan will move us down that path of delivering our strategy. And I'm not sure that's going to be adequate. I think at some point, and I think you've got enough on right now anyway, but at some point I think this board does need to seriously look at the alignment of this with our strategy and its delivery and take stock of where we are.
Bill, did you want to come in on that?
Yeah, I did. So I'd agree with that, Graham. I think I'd refer you back to the North 4 discussion, that one of the reasons that we're in North 4 is because of where we are with strategy. So it's something that we do need to focus on. We had the development session a few weeks ago, and again, I think the operational plan and the joint forward plan have also got to be aligned much more greatly than they currently are. So the operational plan should always be the current year of the 5-year strategy. And I think if we're honest, we're not quite there yet. We have focused on this because it's an absolute imperative. We are performance managed on this. We are scrutinised about this through the North 4 requirements with NHS England. The requirements on strategy, other than the reference in the North 4 exit, have not been as current, and they've not been something that we focused on enough. And we really do need, once we get the operational plan sorted out, to be really clear about the strategy. Without that strategy, we will come up against roadblocks as we go forward. The level and scale of the financial and operational challenge that we need to undertake over the coming years will not be achieved if every year we salami slice the organisations and financial positions. There has to be something that's much more profound taking place in Devon in terms of the pattern of and delivery of clinical care. And that's something that we'll be looking to the Acute Provider Collaborative, the Mental Health Collaborative, to take forward as we stand them up and really get to a point where they're capable of doing this work on and our behalf and across the system. So it is a piece of work that we need to do. We are where we are at the present time, but we do recognise that it's a major ask.
Thank you. Alison Williams.
Just recognising, Chair, that this board is going to be very dependent on the Finance and Performance Committee to be stress testing the submission, because there is inevitably going to be a gap between the expectation and the reality of where the organisations and the system starts, which is going to require some significant mitigation and difficult decision making. So I just wonder whether it might be useful to think as an action coming out of the board today, the amount of time that that committee is going to have on the 27th and who's going to be there. Because it might be appropriate to be bringing representatives from the trusts into that committee for an extraordinary discussion, so that the assurance can be joint between the ICB and the trusts. But also, you know, this is going to be a 3 or 4 hour conversation, I would imagine. It's not going to be something that's going to be done within the agenda of a standard committee. So not for resolution now, but a strong suggestion that that be considered as an action coming out of the meeting today quite urgently, because the board's not going to be able to do that. The committee is going to need to do it on behalf of the board.
Yes, thank you very much, Alison. And can I just turn to Philippa to say, does the board need to give any kind of approval around actually having extra members at the Finance Committee for that?
Thank you, Chair. No, that's not required. To provide assurance to the board, there is no other agenda item for the meeting on the 27th other than the operating plan. So we feel that we probably do have enough time, but we obviously will explore the possibility of bringing others into the meeting. The approval that's requested in the paper will stand if the board agrees that.
Thank you. I'm very conscious of time. So, Alison, I'm going to come back to you.
You just whispered to me that there is a bit of an issue with the committee.
Yeah, neither I nor our chair, Kevin, will be at that meeting. It was discussed at the meeting we had, and there was a recommendation that it would have to seek to get other people to that meeting, but to be meaningful.
Thank you. Thank you. That is in hand. Yeah. Thank you. And I think Sheena Asana is going to be chairing that meeting. So thank you, Sheena. Bill, did you want to come back on that?
Yeah, just that I have had that conversation with Kevin about how we ensure that we are quorate and we can make the appropriate decisions, and that non-executive representation will be there.
Thank you. So with that in mind, can I seek the board's approval? Conscious of time. Thank you very much. Well, colleagues, I think it's now time that we have a little break. So can I suggest, because we are running behind time, that we meet back in just 10 minutes? Thank you very much, rather than taking a quarter of an hour. Thank you. So that takes us to... Thank you very much. Welcome back, everybody. And we're going to come now to the section of our meeting on the Finance and Performance Committee. And Kirsty Denwood is going to lead on this section.
Thank you, Chair. So I'll take the report as read. It does cover 2 meetings, so the 11th of January and the 30th of January. So we have the regular updates that the board have seen in other agenda items for month 8 and month 9 on IQPR, the North 4 exit criteria, operational planning, and the finance reports, which are all elsewhere on the agenda. The areas probably to pull out are the deep dives that the Finance Performance Committee have undertaken. So there's been a couple of bits which have gone as updates. So we had an update on the One Devon elective pilot. We also had an update on the Seaton Hospital, which was more of a clarification around the actual space that was classed as void. And because that's been to the board previously, we've attached the report in the papers so that the board's fully cited on that extra clarification. But the deep dives we had were on investments and workforce growth over the last 3 years. So we had provided quite a bit of insight, really, which will help us going forward in how we tackle transformation, where we've got things right, where we've got things wrong, and also the importance between triangulating workforce, finance, and performance and activity, and that we need to be better at doing that for the operational plan going forward. We also had an initial look at the underlying position and the challenge that presents in terms of the operational plan for 24-25. Whilst we have delivered SIP this year and we should achieve above plan, we haven't done it all recurrently, and therefore that's affected the underlying position. There's also been some recurrent cost pressures, particularly around drugs and prescribing, that have also affected the underlying position, which does mean that the challenge in going into 24-25 is higher than what we'd originally planned. So the Finance Performance Committee were apprised of that situation. There's further work being done on that, and it's all encapsulated in the op plan timetable, which Sam Wadham-Sharp just took us through. We also had a deep dive on the cancer area as well, which John briefly covered in his report. So that was taken to the Finance Performance Committee. That's probably the main areas I wanted to cover. To take questions.
Thank you very much. And could I record the board's thanks to you, Kirsty, for stepping up into the interim role while Bill Shields has been in our interim Chief Executive Officer role. Thank you very much for all the work that you and your teams have done. Are there any questions or comments for Kirsty? No. Thank you very much. So I'm going to take it that we're taking assurance from the committee chair's reports of the Finance and Performance Committee. And I'm going to come now to the Audit and Risk Committee and Graham Clark. Thank you.
Thank you very much. So we met on the 10th of January. There are 4 things that we agreed we would escalate here. Before I get to those 4 items, just to give the sort of the flow of the meeting, we often do look at BAF and risk, and we did again. We looked at the annual report and accounts process. Of course, we're not quite at year end, but that will start as it started in effect. We looked at the conflicts. We looked at 3 reports from our internal auditors. Pleased to say that all 3 of those came out as satisfactory. They were business, capital business, policy, continuing healthcare, and the risk management policy. So that was good to see. We also looked at the single action waivers, because those have very solidly transferred to this committee rather than be aligned to finance. We looked at the annual evaluation of our capability for emergency planning, resilience and response, CPRR. Pleased to say that came out in almost all areas. It's been very good. The 2 areas that we were responsible for, which is the ambulance and the one-on-one out of hours PPG, also came out very, very strongly, so we were pleased to see that. So the 4 things that I wanted to raise today for note and perhaps discussion. The first one is some colleagues, but perhaps not all, were aware that there was an issue raised in relation to process of international nurse recruitment. An independent piece of internal audit, not from ASW, was commissioned by Bill, and we received that report, which makes a number of recommendations. And I think one of the actions from that is we feel that some of the learnings from that should be put into our standards of business policy. So we're quite keen to do that. So that's the first thing. The second thing I'd like to just note is that although we are not at year end yet, ASW's current view about the assurance rating for us is limited. This could yet change because we're not at year end, and it is not a reflection purely of the opinioned pieces of work that we've commissioned. They take it in a holistic view around us over the period of the year. So on the one level, it's slightly disappointing because that would be the same assessment as the previous year. But I think I'm hopeful that the words that come with it, if it remains limited, will indeed flag significant progress. So it's a rather sort of four-level system, which is a bit unfair always. But we are, I think, hopefully now towards the higher end of that limited opinion. But clearly, one would like to think that we can move ourselves up further in the subsequent year. The third thing I'd like to just raise, which we came across, as it were, looking at procurement and single action waivers, is that we, the ICB, does not yet have contracts in place with our providers, despite being near the year end. And I think, Kirsty, you provided some narrative around that, but it was nevertheless of some concern that we should do so, otherwise there will be some irregularity. And it sort of does rather beg the question of what is the point of having contracts that are only signed at year end. So I think we'd be quite keen, A, to get those in place before the year end, and secondly, I think in the subsequent year, and I know there was an aspiration to have a multi-year agreement, but I think we need to be a bit realistic perhaps in getting those in place. So then the last thing that came out from our colleagues KPMG is they provide us with some briefings on sort of emergent best practice and standards and the like. And one of the things they noted was the requirement to include in your annual report progress against your statutory duties, and that includes health inequalities. And I think Shini particularly took a lead in saying we are going to have to be quite careful in thinking about our forthcoming report and to the degree to which we have actually fulfilled our statutory duties in that area. Not saying we haven't, but we need to be careful about it. So those were the four things I thought I should table today. So I open it up for questions or comments, perhaps.
Thank you very much, Graham. And four really important areas. Bill, could you comment on any updates?
I would like to address the first three because I think that they are related. So in terms of the limited assurance, the point made about procurement and contracts and also international recruitment, they do point to a lack of grip and control in the organisation. I think we've got to accept that and recognise that that is a problem. We have had, and we continue to look at the findings from the independent review, and as a consequence of that, we have been looking at contractual arrangements or arrangements that we have with organisations where there's not an appropriate contractual arrangement in place or where the procurement has not followed due process. And again, that relates to things such as the single action waivers, but in a number of cases, it's apparent that irregular arrangements, I think, have been in place. So, and particularly, I think, from the pandemic and coming out of the pandemic, there have been too many instances where verbal agreements have been made, where we've done things in haste, and those are things that will have to be regularised. One thing I would say, Graham, just to correct you in terms of the minutes, I didn't commission the review. The review was commissioned by the executive after discussion with the Audit and Risk Committee. So it's something that was actually commissioned by the Executive, and the report that we've had that went back to Audit and Risk is also being considered by the Executive. And in fact, yesterday we worked through the action plan that arises from that. So just to be clear, it's the Executive who've commissioned that.
Thank you. Tandy Hara.
Just a quick question. Does any of that expose us to any risk, financial or otherwise, in the future?
I wouldn't comment at the present time in terms of where we are, because we have ongoing work that's being undertaken. There is the potential for exposure in terms of financial risk, and that's something that we're working through at the present time. Most of these payments are historical rather than current. In fact, they're all historical, and so we've taken steps to make sure that any current exposure and going forward is limited.
Thank you. Are there any other comments? Yes, James McInnes.
Just in terms of the international recruitment, I know the County Council was working in partnership with the NHS in terms of some of the international recruitment in terms of people coming into adult social care as well. I'd ask the question, if you've had an internal or external look at it, are you sharing that with partners as well so we can all learn together, etc.?
Andrew Millward and myself met with Donna and Kerry Story, and we went through the findings of the report, and we talked about what the next steps would be in a joined up way.
Thank you very much. Are there any other points to raise or questions for Graham? No. Thank you very much for very detailed feedback on that, Graham. So we will take assurance from your committee's report. So we're coming next to the Quality and Patient Experience Committee, and over to Tandy Hara. Thank you very much.
Thanks, Sarah. So this is from a meeting that we had on the 17th of January. We looked at a number of things, some of which have already appeared in most of the reports that we've just seen before this particular one. So we looked at planned care delays and the comms around it, and how that's linked in with the local medical committees and how that's being handled. We also looked at serious incident reporting. We noted that there's a decline in serious incident reporting, but this is partly because of a changeover to the new system of reporting. We did raise concern that might sort of create a space where we have half of the picture and not all of it, and whether we need to be a little bit more aware about what's going on as we transition to the new system, and whether that means that some harm might be invisible. So we agreed that needs a bit of more work that we'll need to look at the next meeting, just to be sure that we're not missing out some stuff whilst we're moving over to the next system. We also looked at the approach to quality, and this was presented to the committee, and they asked the committee to sort of, give its view about adopting the new approach to quality, which is provided or guided under the National Quality Board. This was just focusing around the functions and the accountabilities of the board, in particular, what the committee is supposed to be doing in relation to what the System Quality Performance Group is. So we did agree that was a good approach, but we say that could be looked at as part of the wider ICB governance review. We also looked at the Health Watch report and got some insight about some of the issues that are being reported to Health Watch, and you won't be surprised that quite a lot of what was reported there is what we already know, issues that are systemic around primary care, about access. Although it was quite comforting, I think that where they've got views from people about staff, it was a lot more or a lot less negative in that sort of sense. I think it's sort of just enforcing that actually it is a system issues that we need to work on. But I think people say it would be really useful if that report comes with context so that we can then use it in decision making. We then also looked at urgent and emergency care and issues of harm. You've listened to what's happening to ambulance times and all that sort of stuff. And we also said that actually, at the moment, the sources of harm are sort of expanding and increasing, whilst as before, sources of harm mostly were in spaces where, clinical practice and stuff, but now we have things like strikes and COVID and all of those things that are completely uncontrollable, but have got an effect on harm on patients. So again, we've said we need a comprehensive picture and mapping exercise to understand what harm is happening on that. And again, the committee will look at that next. Then we looked at quality and impact assessment update. There's some piece of work that's ongoing. Again, that was a proposed approach to EIAs, and self-assessments have been done. And again, they'll come back to the committee on that. Other couple of things we look at with mortality work stream. There's going to be a new working group that will be set up to look at mortality, and they're looking at data sets to set themselves up. And finally, we have we're going to look at an independent view of care for a particular individual who has multiple comorbidities, and the South West Collaborative has referred it to the committee to say we need to sort of look at that. Again, we'll look at that and we'll come back and report here. Final one was children and young people. I think we've discussed the issues around children and young people again. Again, that's an issue that will come back to the committee. Thank you.
Thank you very much, Tandy. Does anyone have any points that they would like to raise with Tandy or questions? Thank you very much. Could I just also ask, because the report contains a recommendation that the committee's terms of reference be amended so that we can have 2 independent non-exec members, the ICB Chief Nursing Officer, the ICB Chief Medical Officer, a lay member with lived experience, for example, somebody from Health Watch, an acute provider representative and a primary care representative. So if the board is in agreement that we would need to be, that would be appointed to the committee, I'm asking if you would delegate authority to me to, in conjunction with the interim chair, Tandy, to agree on that appointment. Is the board happy with that? Thank you very much. Any further comments on that? No? Thank you. So we're just asking again if the board would take assurance from the committee chair's report. So thank you, Tandy. Right. We're coming now to the Primary Care Commissioning Transition Committee, and that's over to Judy Hargaden. Thank you.
This is the... I want to raise, thank you. But I just wanted you to note that we look at pharmacy, dental and optical in depth, and this time we had looked at pharmaceutical services and were concerned about the impact of some of the closures, complete closures, and then kind of changes of hours. And there is work being done on a pharmacy strategy and integrating relations at primary care network level. We also took a Health Watch report and some further work that was done on a clinical audit of people who Health Watch had interviewed turning up at the emergency department, and expressed some real concern about this. The qualitative nature of the interviews with people was really good, but conclusions drawn from some of the quantitative stuff were of concern. And so I'm not sure whether Tandy and my committees took the same report.
It would have been the same report, yeah.
There are suggestions that people should not have turned up at A&E, when actually that was the best solution. So if we're going to use these small pieces of work, we need to be really careful about the quality of the statistical work. And you will see that we did manage to get a small piece of dental work off the ground, and you will have heard a lot of national reporting on what's happening with dental, which is small beer in terms of the challenge. We did raise a concern that we wanted the board to action on. I have raised this before, Frank has too. We do feel very strongly that there should be primary care representation on the urgent care board. I don't know what's the best way to do that. That would be an executive decision, but having the primary care perspective in there would be good. We noted the enormous delays in the decision around Teignmouth Hospital, which has led to two practices being extraordinarily vulnerable at the moment, but action has been taken by the executive team, and I believe there was a very good presentation to the scrutiny group about this, which prevented further delays, but we're still in a position where the previous delays have massively increased the cost, and we still have other problems around that which have been discussed before. And lastly, we wanted the board to consider, and I believe it is being considered as part of the organisational change decision, but the regional hub service from which we get support for commissioning dental, optical and pharmaceutical is simply not sufficient. It isn't that they have cut the staff, it's just that now these things are so much more visible and more fragile, there is a need for more work, and I know this is being considered by the executive. Thank you.
Thank you very much, Judy. I don't know, Bill, whether you're in a position to respond to some of the points that have been escalated to us by committee.
Thank you. There are a number of potential investments, I would say potential investments, so I just want to be really clear that the investment group that met yesterday was looking at potential investments and determining which of those would be prioritised for the production of full business cases. They didn't actually make decisions about the investments, and that's something that we will expedite. But there are a number of potential investments that look at some of the areas that have been flagged, particularly in terms of the pod work that's been delegated to the ICB and how we might address that. We also talked about some of the issues that we've got in terms of GP practices and community pharmacies, in terms of the numbers of those that have collapsed or are on the verge of collapse, and that while we need to look at a short-term solution to ensure that we can step in, we also need something that's much more strategic, and I think that's one of the things that's missing at the moment across Devon. We're very, very reactive in that space, and we really need to be thinking about what we're going to do over the next 3, 4, 5 years. I know that Nigel yesterday talked about some of the in the investment group about the experience in Surrey, I think it was, and how we might look at that model and see whether that's something that could be lifted and shifted here. That will not be straightforward. There'll be a lot of discussion needs to take place with practices and with the LMC, but we do need to be really clear about what the direction of travel is and where we're trying to get to, because we are reacting all the time rather than having a clear roadmap to success.
Thank you. Does anyone else want to come in? Because I would just like to clarify with you, Judy, did you decide who was going to take forward the recommendation, or who it should sit with, having primary care representation on the urgent care board?
Sorry, we don't feel that's our decision. I mean, that's not the decision from the primary care committee. We just think it's a very important step. It has been raised here at the board before, and I believe that executives were looking at the best way to do this, but that perspective needs to be in there in the decision making. So we don't have situations like we did last year with the winter money, where some of the initiatives were actually sort of at cross purposes with sustaining our primary care structure too. And not through any ill will, or, you know, there was loads of good intent, but it's just sometimes there are perverse consequences.
Thank you.
So I don't know who.
Thank you. Philippa, could you...
Thank you. Yes. So I'm due to be meeting with Sam Waldron-Sharp, our Director of Performance and Planning, by the end of this week, and alongside the Director of our Programme Management Office, to look at the terms of reference for the System Recovery Board and its supporting boards, including the UEC board. So I'll make sure that I take that as an action into that conversation.
Thank you. So they're very clear that it's a recommendation that's been escalated to the board. Thank you. Alison.
It doesn't cut across the recommendation, which I think is a good one, Judy. But just to reassure that I believe that at the locality UEC groups, of which there are 3, there is primary care representation and that underpins the UEC board. So there is primary care representation in the wider locality-based discussions and decision-making, but the gap is at the UEC board itself.
So I think it would be helpful to take as an action that we have an update on the position, because this has, as Judy says, has been raised before. So thank you very much. Can we come next to the finance reports? And again, thank you very much, Kirsty Denwood, for leading on this discussion. Thank you.
Sorry. I was going to take these as read unless there's any exceptions that people want to discuss. The highlights of these reports have been covered in some of the other reports, the IQPR, etc.
I beg your pardon. Any comments or questions on this? Thank you very much, Graham Clark.
Can I just check whether I'm reading this right? Is it the case that the ICB is significantly behind on its SIP delivery, and is actually further behind than the providers?
So where the ICB is behind is on the strategic programmes, of which it had a bigger share of the overall 60 million programme. So where we've got slippage on that, which was strategic, 30% of that was badged against the ICB. So the main slippage is in the strategic programmes.
Right.
So it's they take a bigger share of the slippage on those.
Share.
Yeah, it was under the risk share agreement.
I mean, just to add to that, the decision was taken between the ICB and the providers about the allocation of risk. So the £60 million that we looked at on a strategic basis, the ICB had the ability to take more of that risk than the provider positions. So it's purely about how we allocated the risk rather than whether we delivered cost improvement or not. And as you'll see in the reports, we also had significant pressures within the ICB that very, very difficult to control, particularly around prescribing, both in terms of volume and also the fact that the inflationary assumptions were very significantly different from what's actually occurred this year.
Penny Smith.
So in the spirit of triangulation, all matters children to the fore of my mind at the moment, and then I look at section mental health services, paragraph 27, and it talks about the links to LD, autism and neurodiversity. I think, Kirsty, this really talks to the need for us to have those quality impact assessments, because that process will deliver opportunities as well as understanding the risks of the constrained budget. So simply to link the quality report with the previous conversation with CYP and this.
If I could just come back on that, Penny, we were in the room yesterday when we were discussing the relative merits of investments and what we might invest in the coming year in 2024, 2025. Children and young people is clearly a priority for us, but at the same time, the investment review that's been undertaken shows that in a number of cases where we have invested, we haven't seen significant benefit. So we know that since the pandemic, we've invested around £75 million in unscheduled care, and we haven't seen a demonstrable improvement in that. We know that when we look at the mental health investment standard, if we benchmark against other systems, we're spending a lot more in mental health. And if we look at LD, autism and neurodiversity, some bases would suggest that we spend about £40 million more than other systems, and yet we know that that's a really challenged area. So what I would say is it's not just about money and it's not just about investment, it's also about delivery, and we really need to focus on that too.
Penny.
Yeah, and actually that talks to the quality and equality perspective. And yesterday we were talking about very often we're good with the ideas, but we're not always good at the implementation or delivering the contract controls that are necessary. So, yeah, thank you, Bill.
Thank you. Does anyone else want to come in on this point? Donna, thank you. Donna Manson.
Yeah, apologies for mixed meeting today, car troubles. I suppose, you know, in terms of improvement in children's services, I absolutely agree with you, Bill. It's not just about the money, but it is about leadership. It's about pace, and across your systems, you have key actions in terms of Devon, Torby and Plymouth in terms of commissioner requirements. So I think I would agree with you in terms of it's not about throwing more money at the system, but it's about having the leadership in place that helps us to redesign and change the culture. So I think the question for us investment is how do you get that level of stable leadership in place to drive the change that's required, and that's considered as an action linked to the areas that are under commission at the moment and require that additional investment that local government's putting in, and we really need to be clear about what that needs to be. But we do have gaps in officer time attending these boards to drive the improvement that's required. So we're not looking for significant investment, but investment to do that, and be happy to working closely with Penny at the moment to shape that up.
Thank you very much, colleagues. So we're going to come now to the section of the board on the action register. And I'm not going to go through all of these items in detail. I'm going to take them as read and ask for your approval that we close action 58 because that has now been taken forward, and to note the updates in respect of actions 52 to 57 inclusive and action 59. Does anybody have anything that they would like to comment or raise on any of those proposals? No. Great, thank you very much. And then we finally come to a section of our meeting which is around questions from the public, and we do have one submitted in advance from Martin Shaw of the Seton Hospital Steering Committee. And the question is this: will the board agree that the handback of space in Seton Hospital be limited to the former ward accommodation as agreed by the September Finance and Performance Committee and ratified by the October board? Well, first of all, thank you very much, Martin, for your question, and to assure you that your email, which provides further background to those concerns, has been circulated to all members of the board. And I just want to respond on behalf of the board, because as we've said in the update paper that was with the finance papers today, the office accommodation above the ward would be relocated to other void area within the main hospital, which is untenanted. And I should stress that the NHS Devon it doesn't have ownership of those upper floors. This is owned by NHS Property Services. But having a completely empty wing facilitates the handback, and it would be easier for it to be repurposed by NHS Property Services. So that is the reason for wanting to relocate the services. And they would be changed, essentially moved to other void areas in the hospital. And we absolutely understand the steering group have raised a concern about that in the past that void space has been used to house a temporary COVID vaccination space. And that would then, of course, be part filled by relocated offices. So the concern raised by the steering group is, what would we do in the event of another pandemic? But I think the point that I would like to make here on behalf of the board is that we have a very clear track record in times of pandemic of pulling out all the stops to make sure that we use every opportunity, not just in NHS spaces, but in other spaces, to ensure that we can take forward a rapid vaccination programme. And NHS in Devon has a very good track record for having done so in the past and would do so again. So I genuinely don't think that would be an issue in the future. But I would also just like to stress again that the vacant space in the hospital costs us around £280,000 a year. And that is simply not good use of public money. And we are tasked with providing good value for money as an ICB. That's money that needs to be spent elsewhere. So in closing, I would just like to say that although we actually hear your concerns, I'm afraid that there is no intention for us to pause the handback process, and that decision has been taken, and it's been clarified through the paper in today's board papers, and that will include the accommodation that is above it in the upper floor. So I'm afraid the board does stand by that decision, and we feel that that delivers best value for public money. But we're looking forward to continuing to work with NHS Property Services and the steering group and the League of Friends, and that we will look forward to having further discussions about this when we meet at the hospital next week on the 14th of February. And that's the answer to the question, Martin, say look forward to discussing in person. Could I also ask the board to note the petition paper that is within the board papers as well around the hospice? So does anyone have any further comments to make on that? Anything that you would wish to add, Andrew, at this point?
Just on the petition, Chair, I understand the issues that local people are raising, because our hospices do a brilliant job, don't they? We have a meeting on the 12th with the Chief Executive of Hospice Care, so we're intending to go through some of the issues with him directly.
Thank you very much. Are there any other items of business that people would like to raise today? Donna Manson.
Firstly, I would just like to note thanks to Penny and Bill and Sue, where for a number of children's service areas are failing currently across the system and local government, across the 3 areas, that out with this meeting that we have agreed a pace-setting meeting to address these significant issues in conjunction with the Chief Constable and the support of the Police Commissioner. Activities around child exploitation and a strategic needs assessment in that area, which I think is important to note to this board, in terms of our offer to care leavers and the expectations of the offer for your care leavers in terms of what should be in place for them that is viewed as a failing because it's not in place. So I think it's very important that I state that out. These are duties that we have as corporate parents. So my question really today is that activity is ongoing. It's important that you know about that because under inspection frameworks, we are inadequate in a number of places. And it's not a case of normal committees meeting to address these. They must be addressed as a matter of urgency. So we've now got a line of sight for weekly meeting so that, as senior leaders, we can make sure these things are happening at pace. But I suppose what I would ask for the board is, where do you get note of those matters when we need to address failings at pace? Because some of the care leaver offer that currently is not in place, that this board has requirement to ensure is in place, does not sit in a children's area, does not sit in an adult's area. It sits at this table in terms of the highest level of governance, as corporate parents. So my question is, can that be considered, please, or an item on the next agenda so that you have line of sight in terms of what's happening, when it's happening, and we can report that to this board and that we're transparent about that. The other thing I would say is that as a matter of urgency, I would ask you to consider when at this board will you be prepared to hear the voice of care leavers in the system, because I think it's very important in order to understand where those failings are, that the voice of the young adults is heard so that we can address these matters. On a positive note, looking at the ambitions of our young people coming through the system, they would love to be employed or be supported by the NHS. We've got the detail of what their ambitions are, and this board has responsibilities and duties as a family firm, as if for their own children, to look at how we mentor, offer and support those young people into pathway and employment. So I think it's important I raise it today twofold. One, to say that the work of some of your officers has been fantastic in recent months and coming into meetings. But secondly, to alert that there are a number of things that need done at pace, and I ask that we have line of sight on them.
Thank you very much, Donna. They're going to bring in Penny Smith at this point.
Thank you, Chair. So we had the discussion around children and young people at the Integrated Care Partnership, as we discussed earlier, and we agreed that we would bring that back into this space. There's been significant work done since the last board meeting on developing our BI approach, and I suggest that we bring the the synthesis of some of that work back into the board next time. It won't be complete in terms of all of the metrics, but those relating to regulatory action will be there, including our corporate parenting role.
Could I perhaps take as an action then that Philippa and I liaise with yourself and with Donna to actually work how we can bring this into the next board meeting, public board meeting? Would you be happy with that as well?
Yes, I would, because many partners across the system, you know, and our districts, you know, our colleagues in Plymouth and Torby, when we get together, we can really take action swiftly. We are under commission, we are under inspection. And I think hearing the voice of the care leavers is a critical part of that, and you know, feeling what it's like for them just now. But also we are under deadlines to improve this as a matter of urgency. It's not difficult things to do. It's just about you being aware of what needs done and having that line of sight on it. And I do think as an ICB there should be that direct line of sight because we're under commission. And also because I genuinely feel with the pace of work that's taking place that we can sort this quickly and build on that success. And I think it's our care leavers, you know, have expressed to us that you are a key partner, and it'd be important for you to get on that journey with us as quickly as possible.
Well, thank you for the leadership that you've personally shown in this area as well, Donna. And I think I wonder whether board members would be supportive of us actually having as our citizen voice care leavers having the opportunity to share their experience and perspectives. Thank you. Sheena.
Yeah, could I just raise the last thing on the agenda, that the petition about hospice care? And I'm really pleased to see that there is a review going on and that it's going to be completed. Just sort of seeking a couple of assurances about this, because I think there's contextual issues, but there's also issues relating to equity and actually cost effectiveness as well. In that as a demographically older area, we will have more deaths in our patch than other areas. So this is going to be an issue, but it's going to be an issue for other ICBs in the future. So we should be leading the way in terms of strategy and understanding. But we are in a very, very difficult position. Yet, from an equity point of view, I'd argue that we're talking about amongst the most vulnerable set of people and their families. You know, dying is very, very discombobulating, and looking after a dying person is incredibly discombobulating and stressful. And I know that we have enormous inequality with regard to end-of-life care within our system, that we're probably, again, it's hard to evidence it, but we're probably providing less support than in other parts of the country, which raises an issue about geographical equity, which bothers me. But from a cost effectiveness point of view, people have to die somewhere. And I'm hearing stories about people being moved from hospices into nursing homes and into hospitals. And I cannot believe that it is cheaper to die in a hospital than to die in a hospice. They're also arriving in hospices too late to actually really fully benefit from that final journey, which is a real issue of quality. And so I'm just really concerned that we do this properly. And I'd like to know that we're costing this, because we would be expecting, probably, given our larger absolute load, we cannot then give a far smaller per capita level of support to each person than somebody in a sort of younger ICB. It's just totally geographically inequitable. And if that is an issue, I think we should be appealing to NHS England about this. But I'm just worried that because it's not one of our target things in performance management, this really important issue is going to be swept aside because we're in NOF4.
Thank you, and I think both Bill and Nigel would like to respond. So I'm going to go to Nigel first, or yes.
Yeah. So many thanks, Sheena. So one of the anomalous sets of services that we inherited when we became an integrated care board and system was the funding for hospice care. Colleagues may or may not know. There are some grant funds that we give to hospices. They obviously, the majority, raise an enormous amount of money through fundraising activities as charities. There is no question that the impact of the pandemic, particularly on fundraising for all charities, but particularly felt by some of our hospices, indeed disproportionately, was significant. And it is true, unfortunately, that during that period and subsequently, people have unfortunately presented often with later stages of cancer, which I think you refer to. We, shortly after we became an integrated care board at NHS Devon, we undertook that review as you outline, which involved all of our hospice partners, and we are continuing that process in order to try and understand better the services that we commission. So it gets back to the rigour that Bill spoke about earlier in terms of everything that we do, and we're working really closely with NHS England's regional end-of-life team on just that, which is how we bring our hospices together. A bit as Sarah said earlier on, this is about access, experience and outcomes for all people in Devon to make sure that we get that high but equal standard of care. And so we have a process in place right now, working, as Andrew said, with some of our hospices in particular about their current challenges, but in order to try and make sure that we get the services that we need for all of our population across Devon, working hand in glove with the hospices.
Thank you, Bill.
Yeah, if I can just supplement that, we have agreed some additional investment in the hospice sector for the current year, and we have looked at a proposal which will come back about investment in hospices next year, and also will address some of the equity issues in terms of relative funding between the hospices in different areas. The point that Nigel referred to is that we had 3 different ways of doing this across Devon, and we're trying to rationalise that so that we can ensure that the equity is resolved.
Lots more interest. I can see Judy and Frank would like to come in. So Judy Hargaden and then...
I'm delighted to hear that this detailed work is going on. I wonder if we might agree as an action that this will come back to us. I think you say it will be completed in the spring, so if we could agree which meeting it would come back to, because I think it's very helpful for us to understand the detail and the proposals you have for going forward.
Thank you. Frank O'Kelly.
Thank you. I have quite significant experience in this area, having spent 20 years working in a community hospital and managing lots of deaths in that environment, and now 25 years out in the community. Most of the population want to die at home. It's an absolute privilege as a GP to allow that to happen. So this isn't all just about hospices. It is about how we prepare for the fact that we have a population that is going to be 25% over the age of 65. So can we, by all means, we need to look at the funding for hospices, but a lot of people die at home, managed by their GPs with minimal input from some of the hospice care services.
Thank you.
Just a clarification, many of the hospice services are now provided in the community, and in fact they are changing their bed base and bed ratios to recognise exactly the point Frank made, and that is part therefore of the work that we're doing.
And just to flag, of course, that there are particular concerns about the hospice at home service raised by North Devon Hospice and Exeter. Thank you. Any other points that people would like to raise?
Chair, may I say something?
Oh yes, I'm so sorry, Hisham. Yes, Hisham Khalil.
Just very briefly, I've been involved with others in end-of-life care, and I think quite related to the issue of hospice care, I think is end-of-life care. And as colleagues have been saying, this doesn't just happen in hospices. And so I think there is a responsibility for the system to look into the training of healthcare professionals into their generality for end-of-life care, and making sure that the population who are in that quite challenging and difficult situation have the best quality of care ever. And I know that the Devon Training Hub has completed a project of end-of-life care for a number of the training professionals that ended towards the end of last year and has had its evaluation. So I just wanted to hopefully that the review does include that as well, and not just the place, but also the training of the healthcare professionals. Thank you.
Yeah, indeed, and in fact there are St Luke's Hospice in Plymouth. They themselves have got a training programme for colleagues in nursing residential care home settings. So picking up on the point that John Taylor made about our clinical and care professional leadership framework, it's such a broad framework that we need to make sure that it covers all of the appropriate areas. So yeah, absolutely, Hisham.
Thank you. So if there are no further, oh sorry, I beg your pardon.
Sorry, it's just that I'm sure Anthony would probably say this if he was here, but one of the work streams under the Urgent and Emergency Care Recovery Programme is about strengthening the end-of-life pathway, because the funding is only one element of this. This is about having a real clear end-of-life pathway that straddles primary care, the voluntary sector, hospice care, social care, and also acute care, because the worst outcome for somebody is right at the end of their life, they're putting in an ambulance and end up sadly passing away in a corridor in an A&E department. So that end-of-life pathway work is so critical. And the hospice and the funding is but one part of it. So I just wouldn't want the board not to think that that work was going on, because I think Anthony probably would have raised that if he was here.
Thank you for raising that on Anthony's behalf, and we'll make sure that's incorporated in our report back to board. Thank you very much. So I'm going to bring the meeting to a close, and thank you to everyone who's contributed today. Thank you.